All right. So today we'll be looking at issue concerning ethics in healthcare, and then it's going to be from a physiotherapist perspective. I hope we are all physiotherapists in the group. I hope the organizer, I'm not having a mix at class today, because I thought it should just be for physiotherapists. So please, if there are other specialists in the group, you just try to look at it from either an occupational therapist view or speech therapist or what other rehabilitation program you're running. So the agenda for today's workshop will start with an overview of ethics in healthcare, and then we'll look at ethical principles in physiotherapy. We're going to discuss so many case studies and group discussions. And then we'll look at professional boundaries as well as the patient right. What right do the patient have? And then finally, we're going to look at ethical decision-making framework. We're going to interact very well, and then we'll see how we'll conclude in the second aspect. We'll start by presenting our theoretical case, and then we will now do a case and group discussion. Then we'll go for a break. After the case and group discussion, we'll come back, and then we'll see how to tidy up our discussion. So we hope to have a good ride. As a way of introduction, I said ethics refers to the principles that govern behavior, and it focuses on what is good or bad. Ethics tells us what is right or wrong. So you cannot be a professional if you do not have any professional code of conduct or ethical conduct. So it is this ethics that guides us on what we do as professionals. I said ethical practices build trust between the healthcare providers as well as the patient, because you can't treat a patient without trust. So if the patient believes there are ethical practices that guide your profession, then he knows that following the ethical practices is going to build a trust between both the patient as well as the therapist. I said ethics ensure that the patient's rights are respected. You must know, like in our client or in every client, that when there is a doctor-patient relationship, the doctor always feels he's superior, because the reason the patient has come to see the doctor is not the doctor that went to visit the patient. So he feels he's the one who will be the alpha and omega of the situation. But no, with ethics, we must ensure that the patient has his own or her own rights, and those rights must be respected. I said ethical principle promotes fairness, especially in the distribution of healthcare resources. We must understand that the resources, especially in urban areas, are not likely to be the same resources in the rural areas. So if there are no ethical principles, there may be no fairness in the distribution of these healthcare resources. At the same time, I say ethical practices uphold the integrity of the professionals, fostering a culture of honesty, accountability, and transparency in whatever they do. According to the World Physiotherapy in 2022, they mentioned that everyone who seeks the services of a physiotherapist has the right to service, regardless of age, gender, race, nationality, religion, ethnic origin, creed, your color, sexual orientation, disability, health status, or politics. Now, this is all encompassing. For us in Nigeria here, you know, we're very spiritualist. I don't know how to put it. Our spirituality is high. It's either somebody is a Christian or a Muslim, and then you now have a gay. A gay wants you to treat. why it is happening? God forbid, you know. But this is what the profession is saying. Whether it's from MPC or PDP, that shouldn't matter. Whether it's from Northwest, Northeast. So this is what is called, it has to be all encompassing. So your ethical principles will not allow you, you know, to disenfranchise somebody from receiving treatment based on whatever is presenting with. Like you said, sexual orientation. If somebody say he's gay, and then your religion affiliation does not allow you to that, so you're going to be having this ethical dilemma. And what do? Are you going to uphold to your professional ethics, or you want to uphold to the religious orientation? So one has to be clear in what you should do. The ethical principles are shown. There should be no segregation, and no any individual should be denied their right for treatment. I said ethics provide a framework for professional conduct, helping the professionals to navigate complex situations and then make decisions that align with moral and professional standards. Now let's look at the core ethical principles in healthcare. In general, physiotherapists and every other healthcare, there's what we call the core ethical principle. This is germane. I mean, it has to be there. So, number one, in all professional ethics in healthcare, the first thing every person must know is the principle of autonomy. And that means one must respect the patient's right to make their own decisions. Now, if I have to respect the patient's right to make their own decision, it means I must be able to support the patient with all information that will allow the patient to make his or her own decision. And you know where I'm going to at that point. When you say a patient consents to do or for a program or for a procedure or a treatment, without you telling the patient everything that has to do with that procedure, how do you expect, the patient to make an informed decision? You have to give the patient all the information that is needed. So that's the principle of autonomy. Now we need the principle of beneficence. That is, whatever procedure, treatment, or intervention you're going to be giving to that patient, the professional must be acting in the best interest of the patient. That is the best the patient can get as far as that your resources is concerned. So you know that whatever you're giving to that patient is not going to harm the patient. Whatever procedure you have done is in the best interest of the patient. So that principle of beneficence must be upheld. Of course, there's also the principle of non-maleficence, in which, in whatever circumstances, you must do no harm to the patient. So it is better when a patient presents with something you don't know or you cannot attend to refer the patient or avoid giving any intervention. So whatever you will do to avoid harm must be upheld by the professional. So that principle of non-maleficence is also a key principle in healthcare. So you must do no harm. That's the golden rule. Do no harm to the patient. Another principle is the principle of justice. At this point, you want to ensure fair and equitable treatment. In justice, we're going to be looking at so many things under justice in terms of, equality, equity. We're going to look at all these things in terms of what will benefit the patient best. Okay, so these are issues that we will have to deal with as we move. Another principle we also need to look at is the principle of fidelity and veracity. These are principles that has to do with, you know, looking at issue that contains trust and confidentiality. You know, it has to go through honesty and then truth telling. So whatever you want to do, you must understand the confidentiality and the trust the patient has bestowed on you. Because you have the privileged information that your patient is HIV, and then you go around sounding it elsewhere. You know, you have lost the trust of that patient, and of course, you have breached the principle of confidentiality. Okay, so we're going to be looking at all these principles one after the other. So let's start with autonomy. At this point, we're talking about respecting the patient's right or respecting the patient's autonomy. I say autonomy refers to the right of the patient to make informed decision about their own health care. It means it's not just what you come to tell the patient, okay, you have malaria, I'm going to be doing this. So the patient also should be given all information about what is malaria, how it affects its health, and what are the remedies? What are the different options? Do I take by oral dose? Am I supposed to use by IV, or I can use IM injection? Which one will I prefer? Let me understand the risks and benefits, then I make my choice. And that choice I have made may not be the one that the professional wants best, but of course it must be able to respect my own decision as a patient. So I said autonomy is based on the principle of self-determination and respect for individuals' capacity to make choices. Now, I may not have the capacity to make the choice if I've not been given the necessary education or information about the issue at hand. So therefore, autonomy ensures that the patient have all the necessary information to make an informed decision about their treatment. I say this information should include the nature of the treatment, the potential risk, the benefits, what are other alternatives, and the potential consequences of refusing treatment. I haven't given the patient the whole of this, and should in case the patient now refuses the treatment, what do you do? Are you still going to respect the patient autonomy, or what do you do? We say autonomy should be based on voluntary, decision. We should get the consent of the individual without coercion or undue influence. So it means until and unless the patient has understood the whole process, and then his decision, whatever he made, should also be respected. Now let's look at this first case scenario. I have a scenario of Mrs. Smith, who is a 65-year-old woman. She has been experiencing chronic knee pain due to OA. Mrs. Smith has been under the care of a physiotherapist, PTJJ, for the past 6 months. I said, despite conservative treatment, including physical therapy exercises, pain management strategies, lifestyle modification, Mrs. Smith's pain has significantly increased, affecting her mobility and quality of life. Ladies and gentlemen, at this juncture, is it that the physiotherapy is not working? I hope some of us are in orthopedics. Please unmute yourself. I want us to talk.
Yeah, some of us are orthopedics.
Now, look at the three bullets I gave at the beginning. I said, despite the conservative treatment, which include physiotherapy, exercises, pain management strategies, that is using your shortwave, ultrasound, TENS, and others. Those are pain management strategies. Lifestyle modification, weight reduction, using of walking stick to reduce weight from the knee and all that. I said, despite all this, Mrs. Smith's pain has significantly increased. She's having physiotherapy for the past 6 months, but her pain is increasing. Now it's affecting her mobility and quality of life. I'm asking at this point, do you think that what the physiotherapy has been given has not been very effective? Somebody is sending some text message. Sorry, just feel free to, yes, somebody said, I think physiotherapy did not make the right diagnosis. Well, I thought I gave out the diagnosis. I said she has OA, and the concern is the knee pain due to OA. So what other differentials do you want to bring up?
Well, good morning. I think maybe the patient is not well informed about the clinical diagnosis and she's not carried along with the treatment plan. So maybe most of the whole program, she's not really compliant with it.
Aha. So there's a possibility, you know, these are the different possibilities we're trying to talk about. Perhaps there are some things that the physiotherapists have not been doing. Do you understand? That would make his intervention really effective. But at this point, we could, let's finish the case. I said the physiotherapists recommend a more intensive treatment approach, which is invasive, involving intra-articular corticosteroid injection to reduce inflammation and alleviate the pain. So now, is it within the prerogative of the physiotherapist to recommend injection into the knee? Yes, please feel free to speak. Should the physiotherapist, is he allowed to recommend injection into the knee?
The physiotherapist could suggest that based on what he has been applying and not having any help,
yes,
recommend to members of the management team, treating the patient that administration of steroid into the knee could be a possible treatment modality that could relieve the patient of the pain. He or she could suggest to the other members of the medical team if they could do that, and if they agree to this suggestion, such injections can be administered. The overall aim is to improve the patient's well-being and to alleviate the patient's the pain that he is having. I'm sure the other members of the team will agree with that suggestion. Thank you.
Yes, anyway, thank you so much. I didn't get to hear very well. I was struggling. It's like you're far away from your mic, but I do pick that you agree that the physiotherapist could suggest, right? Is that your point?
Yes, sir.
Okay. Yes, this is just a question for us to understand as physiotherapists. You've been treating the patient with all your modalities and the patient seems not to be responding. It is still within your powers. In fact, in the UK presently,
hello, sir.
They have... Yes?
Good morning, sir. Sir, my own opinion, sir, is beyond the scope of physiotherapists to prescribe the
steroid injection. Yes.
Injection. So the best is, as a physiotherapist, is to refer the patient to a medical team to go and do a further investigation. Then they will now prescribe the appropriate medication for the patient. Probably the patient has a contraindication with or in relation to a corticosteroid. Thank you, sir.
Okay. Thank you so much. Well, I think this is just where I'm trying to catch at this point, and I'm trying to call the attention of physiotherapists that you should know that it is within your powers, it is within your prerogative, that after you have reviewed your patient, that's the essence why we're moving from BPT to a DPT program. This is to give you a further autonomy, because at the UK presently, they have moved away from just recommending the patient for intra-articular injection, but now have the powers to even do the injection themselves as physios. So what the colleague just mentioned now, it's where we used to be. I'm telling us to move now. We have a further step ahead. That when some of your non-invasive therapies are not working, you have the powers. You have to give the patient all the information. You could recommend. Your recommendation doesn't mean it's you that you're doing it. Do you understand? So you still have that powers to recommend. Now, This is not where our ethical dilemma is coming. I just took this in for us to get an information that we are supposed to do that, okay? Yes. Now, the PTJJ, when he recommends this intensive and invasive therapy to Mrs. Smith, he explains the procedure, its benefits, the potential risks, as well as other alternative options to the intra-articular injection. And he did this ensuring that Mrs. Smith understands the information provided. Now, if you give somebody an information, how do you ensure that the patient or that person has understood your information? Don't forget, Mrs. Smith is 65 years old. So we're looking at somebody who is a pensioner. We're looking at somebody who is a retiree in our context in Nigeria. So how would you ensure that you give an educational information? How are you sure that that person has that cognitive tendency to have understood what you're saying? Yes, please. Yes, somebody wants to help us? Please feel free to talk. I believe we keep talking to our patient, do this, do that, and all that. How do we ensure that the information we gave are understood by the patient? Yes, please. Because this is the issue that surround, the issue about informed consent. So just because you have informed the patient, you're not sure if the patient really understood what you have said. So you want the patient. Yes, please.
Good morning, ma.
Well, I am Bello. Bello is the man's name. I don't know if my voice is sounding feminist.
Can you hear me? I want to say something, ma.
Yes, I'm trying to correct you, Mrs. Adeni.
Okay.
I said Bello is the man's name. He's not a woman. But I don't know if my voice is sounding feminist.
Sorry, I'm very sorry. I'm very sorry, sir. Good morning, sir.
Please go ahead.
Okay, so about passing information to our patients in the clinic.
Yes.
What I usually do is that when I pass an information to them, I tell them to repeat, like to explain what I've said to me back. So I know that they actually understood what I said, and then they can make their informed consent that way.
So this is just where I want us to hammer. You give a patient information and you want them to say it the way they understood it back to you. What I've said, what did you really understand about it? How do you think about it? Okay? So you want to be sure they really understood, and then which one will you prefer? Don't forget, in giving them information, I said he explained both the benefit and the harm. And not only that, he also provided alternatives. And now, if you don't even want injection, we could do acupuncture, we could do something else, So alternative therapies we could use. Perhaps we are eating some type of food that are inflammatory in nature. So let's see if we could change your diet, maybe it will help. So, I told her about the intra-articular injection. I've mentioned the benefits and risk. I'm now bringing about, we could also do acupuncture, perhaps it may help. I could also think about, if we change your diet? So I gave her other options. Which one do you think you want to do? All I have given her their benefits, their harm, and risk, vis-a-vis the cost, because this is also very, very important. Now, let's continue with this case. I said, after careful consideration, Mrs. Smith declined the recommended corticosteroid injection, just like how many Nigerians will not accept, because one shot of the injection may cost her over 200,000 naira. And then I'm telling you, after because you have to tell her that after 3 months or 6 months, the pain may come back. If you are lucky, 1 year. So she put all these things together and felt, well, she declined. She doesn't want it. She expresses her concerns about the potential side effects, such as risk of infection and the temporary nature of the pain relief. So Mrs. Smith also shares her preference. She wants more of a non-invasive therapy or treatment, and then she had desired to explore alternative therapies such as acupuncture or dietary supplement. So now the question I want to ask here, how would you uphold that principle of autonomy in this case? Yes, please, feel free to respond. We just discussed autonomy, which I said it is side by side the informed consent. So what are the three issues you want to raise for me in terms of autonomy here in this case? Please feel free, any person can discuss. Dr. Sunday, you want to say something? Dr. Sunday, I know. Can you hear me? It seems to be focusing, but I'm not sure if you can hear. Yes, please. Any person? I just want to be sure if we have understood the discussion I said about autonomy.
All right. Good morning, sir. Hello, sir. All right. Thank you very much, sir. So since the patient has expressed a capacity to make choices, and we are very certain that she is not making those she's making the choices like out of a clear head and all of that. Maybe I would want to reiterate the potential consequences of a treatment that I feel might give her better improvement and better outcomes. And if she's definitely insisting on going for the alternative, the options, then we would encourage her to, I guess I'll just encourage her to proceed with it and guide her through that the alternative options and ensure that at least she gets some outcomes, good outcome from it. Yeah. Thank you, sir.
Yeah. Thank you so much, Eniola. It's quite interesting. But I'm trying to see, how do we place that principle of autonomy? I want someone to discuss the principle of autonomy based on this case. Eniola has accepted that the patient has shown her concern towards an invasive therapy. And then she has also expressed her preference for other non-invasive therapy. So if you are the physiotherapist in charge, what would you do? Which decision will you make is what I'm asking, based on the principle of autonomy. I just want us, I brought in this case at the moment I finished discussing the autonomy. I just want us to use that principle of autonomy and put in this case and see how it's aligned. Because most times we meet our patients in the clinic, and then this kind of situation arises and we don't seem to understand that we are breaching the principle of autonomy, which is a key principle in healthcare, in ethics. Okay, yes, Fatima Halilu, yes, your hand is up. Can you speak? Unmute yourself.
Good morning, sir.
Yes, go ahead.
I think in this case, since the patient has already expressed her preferences, in which form of management plan she prefers, it is upon the physiotherapist to respect the patient's preferences. The patient does have the right to even refuse treatment at all, and there is nothing that can be done. So what the physiotherapist can do in this case is, since the patient has expressed that she would not mind non-invasive methods like the physiotherapist, the therapist can sit with the patient and discuss, and they both come up with a way that with treatment management plans that are both effective and within the patient's preferences.
Yes, thank you so much. That's where we're going to. That the patient has categorically mentioned that she has declined that injection. Now, we don't want you as a physiotherapist to now feel bad that I recommended this patient, I have examined you, I have seen that this is what will benefit you most, and now you say no. And then the physiotherapist will like, let me just send you to someone else. That is where you have breached that principle of autonomy. What we want you to do based on ethics is that preference the patient has shown for non-invasive therapies or treatment is what you must upheld with. So you must have to look for a better way or a better strategy of treating the patient with a non-invasive therapy. Number two is you must accept that her decline of that in good faith, not getting angry or not getting frustrated with the patient, not following your recommendation. Then the third one is you must also be able to find a means of sharing other therapies you have not used based on what you are seeing presently. So this is what I'm trying to say in this case here. So please, let's look at it. I put up my ethical considerations for us to see. I said the physiotherapist must ensure that Mrs. Smith is fully informed about the recommended treatment, its risks and benefits, as well as alternative options. Now, this first bullet means it's informed consent. So this is the first ethical issue we have. She must have the full informed consent. And that's where we have trouble among our medical colleagues, especially the surgeons. You know, somebody comes with back pain, you just tell the patient, okay, based on your MRI, there's a compression of the disc on your L3, L4, L5. You can be well until we give you we do an decompression surgery. Now, this decompression surgery, you are not telling the patient what are all the risks and benefits. Because if you tell any patient that after this surgery, there is a likelihood that the pain could even move away from this level we are doing the surgery to another side, there is a possibility that this pain, even when it's relieved, you may not be able to do this, do that. You may not be able to, the pain is likely going to surface maybe after 3-4 years based on other degenerative tendencies of the spine. If you give them all this information, they're not likely going to do what? Accept that decision for surgery. So therefore, they don't give all the information. They just tell you, okay, the moment there's a compression, we're going to go inside, we lift the compression, and then you go back, and then you'll be fine. You know? That's what they give you. There's no way that the patient will not sign that informed consent. So please, we must understand that your informed consent must give full information about the recommended treatment. It has to go about the nature of the treatment, the risks involved with the treatment, the benefit, and then what are other alternative options that can make me get the same benefit, even if it's going to take longer. So all this is the first thing we must clear. Number two, I said the physiotherapist in this case respect Mrs. Smith's decision to decline the recommended treatment. Therefore, it's not saying since you have declined the treatment, sorry, I'm discharging you, or I'm referring you to go back to your orthopedic surgeon because nothing is working. No. When the patient declines the treatment, you must accept the patient's decision in good faith. Therefore, opening other rooms, other options, especially in this case where the patient has also shown her preferences, you know? So we must give her other choices that she would use to get the same thing she's looking for. So number 3, we'll see that in this case, the physiotherapy has been able to maintain an open and supportive communication. This is also germane to informed consent or to autonomy. It is, you must give the patient the freedom to ask you any question about the condition. That patient should be able to ask you, and you must be able to give a truthful and correct information as much as possible as you know. We must not, try to hide information for some personal gains. You will realize that most orthopedic surgeons or neurosurgeons that want to do back surgery, they know that there is a possibility of back, what we call it, the failed back syndrome. There's a possibility that this surgery may not give the patient what they want in the next 3, 4, 5 years, but they're not going to mention all that to the patient, not because they don't know, just because if the patient has those information, that patient may decline the treatment. In fact, I have seen a case of a surgeon whose patient came in with a disc compression and a pain intensity of VAS of about 10/10. And the surgeon mentioned that, you see, woman, there is nothing we can do for you. There is no drug that can help this thing. We just have to do the surgery. And can you give me any pain reliever? You will not believe that patient just gave, that doctor gave only paracetamol. How can paracetamol help a disc inflammation when the patient is telling you 10/10? The idea is that when the patient goes back home and then that pain is still killing, that patient will have no choice than to come and consent for a $2 or $3 million surgery. So there is a way of coercion, of forcing the patient to come and take the intervention that you did. And they did not give the patient alternative therapies. They didn't even see a physiotherapist. There is nothing they can do except that surgery. So there are really breach of ethical issues here in such situation. But for this, our physiotherapist has been able to open, and support the communication with this woman. He has been able to provide her with all information in the way that she will understand. And he has shown that he's respectful to Mrs. Smith's concern. So this is how the therapist is supposed to handle that ethical issues. Of course, we see that the physiotherapy was able to tailor the treatment plan that he has now that must align with Mrs. Smith's preference of what? Non-invasive therapy. Because you have to ensure that her values and goals are also the center of her care. This is what she wants. I believe we used to know, like the issue that concerns, there is a religious body in Nigeria, they call them the Jehovah's Witness. Now, in Jehovah's Witness, they don't allow for blood transfusion. Now, if she comes in with an anemia of 10 or 5, what would you do if they have refused consent for blood transfusion? What do you think we're going to do after giving them all the information? Ladies and gentlemen, how do we handle that case here? Hello? Are we stopped with that?
Improving we accept it in good
Yes.
faith.
You said?
We accept the patient's option choice.
Yes. So we will have to accept.
And then the doctors will come up with alternative options to improve the blood level.
So we have to accept a decision of not wanting transfusion based on her religious value. Is that it?
Yes, sir.
Now, you know that a patient who has a 5% PCV is at the risk of losing their life.
Yes, sir.
Now, and the doctor has mentioned this to her or him, but she remained resolute that this is what aligned to her faith. Do you, as a doctor, allow the patient to die, or you're going to force yourself to give the blood?
So we won't allow, it's not like we are allowing the patient to die. Just
Yes.
like you mentioned, a part of informed consent is making the patient know the consequence of every option that is available. So
Exactly.
if a patient has made a choice, then they've also chosen the consequence associated with that choice. So it's not like we are allowing them to die, but we'll just work within the other options that they have chosen and allow the consequences just play out, if there would be any eventually.
Exactly. So we need to understand that. Yes, thank you so much. Thank you so much. I really appreciate. That is the point I'm trying to make in this case, that we must understand that we are not allowing the patient to just die down, but according to the principle, we must look for other options. After explaining the consequences, if anything happens, you are not going to be blamed for whatever consequences that happen, but we're not just going to leave the patient and go. Do you understand? We will have to find other alternatives. It's like, okay, let's put in normal saline 50 by 50. Let's put in some drug, solubles, and we just have to do something. I hope we're getting it at this point. Can we make progress?
Yes, sir.
Okay, thank you. So let's look at another principle. We talk about the principle of beneficence. I said beneficence is an ethical principle that refers to the obligation to act for the benefit of others. So it means whatever I'm trying to do for my patient, I have that obligation to be sure that it's only something that will make them feel better. I'm just going to do it so that it's in the interest of the patient. Because what I'm emphasizing here is, that our ethical issues are already being compromised in our situation presently in Nigeria. We all know that sometimes most of us will, for instance, let me talk about people, ourselves, our colleagues in physiotherapy. We realize that, okay, using this back corset, we have seen the researches that tells us when you put back corset, what it does eventually is to, it's going to put all the muscles into inactivity. So the muscles will also not be functioning. You are causing disuse. And then the patient will have more likelihood of recurrence of their back pain. But if I look at it that if I'm selling my corset, if the corset, maybe if I want to sell it for 20,000, 25,000 naira, and then knowing that this thing may eventually come to harm the patient, but I'm looking at, this patient is going to be buying it at 25, I'm making about 10,000 naira or 5,000 naira. I still go ahead to sell the corset just because I know it helps for some short time, but it's not because it helps that I'm doing it, because of my own selfish gain. So that is a harm. That is a harm. That is not a beneficent intervention. What you will give for the patient to be beneficial is whatever you are doing for the interest or in the interest of that patient is what you call a principle of beneficence. Because if it's not benefiting the patient, then that thing is very, very wrong. And you are breaching an ethical principle that is liable to court, litigation. So, and unfortunately, because in Nigeria, most of us, we don't take the doctors to the court. Nobody takes the doctor to the court. We keep doing these things, carelessly. I believe most of us who have ever worked in UK or somewhere else, we know that you don't joke with that. You don't joke with it. So we must understand that the principle of beneficence is that whatever you're giving to your patient must be in the interest of the patient alone. We have to be doing what will promote their well-being, and then we're taking action that will contribute to their health and happiness. We should know that physiotherapists must prioritize the well-being of their patients, aiming to improve their health outcomes through effective treatment and compassion. Okay? So we have to prioritize that is the patient that is our key in whatever we do. So therefore, we must understand that prioritizing the well-being of your patient involves both preventing harm and then actively promoting good by enhancing the patient's physical, mental, and emotional health. I say beneficial means you have to act in the best interest of the patient. You have to prioritize your patient's well-being in every decision you are trying to make. You have to learn how to balance between the benefit and the risk that is involved in whatever intervention you want to give. And of course, you must be able to evaluate the potential positive outcome versus the possible adverse effect. So these are issues that surround the principle of beneficence. You know, can we go ahead? Can we go ahead? I have a case also I'm going to be presenting, which is about a principle of beneficence. I said, it is how do we decide on the most beneficial treatment plan for a patient? This is a 55-year-old man, Mr. James, who has been presenting to the physiotherapy clinic with chronic low back pain that has been affecting his daily activities and work life for the past year. Mr. James works as an office manager and he lives a sedentary lifestyle, and of course he has a history of hypertension and mild obesity. His doctor has recommended physiotherapy as part of a comprehensive management plan. Now, Ms. Lee is the physiotherapist, and of course she has conducted a thorough assessment. So we assume that Mrs. Lee identified that this chronic low back pain is likely to be due to poor posture, muscular imbalance, and the sedentary lifestyle. And of course, she identified that the risk factors related to Mr. James' overall health include hypertension and obesity, and which are likely to affect his treatment and recovery. The question here is, what are the ethical dilemma or the ethical issues? I'm waiting. I'm not hearing any person speaking.
Sir, we lost you for a minute.
Oh, sorry about that. I was asking that what are the ethical issues in terms of the principle of beneficence we can pick out from this case? Do we go through the case again? Don't forget, I mentioned that the principle of beneficence is that whatever intervention you are giving to your patient must be in the best interest of that patient. Whatever you're doing should be what you think is the best the patient can get, or what will help him the most. And of course, what would reduce any harm. And of course, the principle of beneficence is that you're not looking for anything from the patient than his well-being. You just want your patient to be happy. So, and I will say this is a case of a 55-year-old man who presented with low back pain. Of course, in his comorbidity, he's hypertensive and he has obesity. The man has been living a sedentary lifestyle, so perhaps sedentarism is part of his comorbidities. And of course, we said he should go through physiotherapy. I'm trying to ask us, in this case, we identify as physiotherapists that poor posture, muscular weakness or muscle weakness, and sedentarism are the major issues he's facing. Of course, apart from those risk comorbidity of hypertension and obesity. Now, what do you think will be the best treatment plan for this patient? I know some of us are not in orthopedics, but those in orthopedics.
So one, can we say lifestyle modification?
That is germane. You can't do without that. So now the problem is lifestyle modification. What do you mean by that? What would you do for him as a lifestyle modification? You want to change his job?
Not necessarily changing his job, sir. But
so what would you do?
One, you have to consider what his daily routine is.
We have mentioned to you that he's an office manager.
Yes, which means
so
maybe he works 9 to 5. Yes,
he sits for a long time.
Okay.
So what would you do? I think the first thing is you're going to fix his ergonomics.
I think you design the chair design that he uses to sit for that length of time should be modified in a way that it will help to align his spine so that as he sits, his lower spine where the pain is coming from is properly supported, and you will encourage him to sit more erect, not to sit in a slouch position. And secondly, while he sits, he should push the chair that he's sitting down underneath his table so that while he's writing, there is no gap between his spine and the backrest. Then thirdly, while he's sitting, as he walks, at intervals, you will encourage him to get up from his seat and take a short walk around his office so that he can now relieve his back muscles and his gluteal muscles while he takes that short walk around. It will give relief in the area where he has been sitting on previously. So as he does that routinely, gradually, he will begin to feel much better. Then as he continues with the job, because you cannot change his job. So what you do, you keep encouraging him to keep doing this wherever he goes. And wherever he goes, he should insist that the type of chair he uses to sit is such that the back is adequately supported. Well, there is no chair available and is given a stool or a bench to sit, he should ensure that he pushes the bench or the stool close to the wall so that the wall becomes his own backrest. Once he's able to do that, the cause of the stress to the lower back due to prolonged sitting will now be minimized, and by doing so, the fatigue in the muscles that eventually leads to pain at the back will also be eliminated. So these are part of the lifestyle modification that you now advise him to adopt so that he can now have a more lasting relief from the pain in the back. Thank you, sir.
Thank you so much, Mr. Udi. That has been very wonderful. That's everything we want you to say about ergonomics, you know? So the office ergonomic is the first thing you're going to evaluate. You need to go there. It means you're going to take the pain in going to the office of your client to just see. Sometimes you go to their car. You have to go to the car to see how does the car fit in if he drives. Sometimes it is the car seat that is giving the patient the problem. You know, so it means who pays you to go there? You can claim it's not your clinic, but you're doing this in the best interest of the patient. So that's the principle of beneficence we're talking about. You go in there to be sure that that thing has been aligned properly to what will solve the person's problem. You took the pain to drive your car to the office of the man or of the person or your patient to look at the office ergonomics. you'll be shocked that sometimes you just get there, you just see the problem, and then the moment you solve that office problem, you're done with that. So I thank you so much, Mr. Udi or Dr. Udi, for that contribution. It's quite helpful. So we need to look at it from that perspective. So what other perspective are we supposed to look at? We've talked about the lifestyle modification. What other things? You've just captured only one out of all, because he mentioned to us that possibly, when you sit for too long, you're going to be having ischemia of the back muscles. Of course, you have not even talked about the pressure on the spine, where the low back pain is coming from. Prolonged sitting gives more pressure between the discs and the discs and the intervertebral space, the intervertebral foramen, giving room for more compression of the disc. And of course, it will give you more room for stenosis. So you're likely going to have all these problems with prolonged sitting. So he provided, he advised and suggested that in terms of his treatment, he should avoid prolonged sitting. And then he gave the time interval where you should move around and then come back for your spine to realign itself. So we're very helpful. Those are very helpful tips for us, But you don't have been able to do that if you're not be able to evaluate your patient properly, and then you didn't take the pain to go to the patient's office or to go to the patient's house or car to see what is really giving the problem. So here we're talking about the principle of beneficence that you're going to be doing that is not part of your, you didn't build the patient to go to their office. So, but you're taking it upon yourself in the interest of the patient. So please, we have to look at it in this faith. Number two, there are other comorbidities I mentioned in terms of hypertension and obesity. How do we address that?
Let's reduce the
Yes, please. Who is speaking? Zulaiha? Zulaiha, do you want to talk? If you're not talking, please mute yourself so that some other persons can talk.
Hello, class. In terms of hypertension and diabetes, the lifestyle modification that we advise the patient to adopt is to observe proper diet control, ensure that foods that are very high in fats are reduced, then his or her carbohydrate intake should be regulated in such a way that he or she does not take too much carbohydrate or fatty food, and that his dinner as early as maybe as late as 6 p.m. every day, and regularly take short walk down, so that whatever fat he or she has acquired over time, gradually with increased activity, he or she can now reduce the fat in the body. Then he should also avoid unnecessary indulgence as regards excessive intake of alcohol, excessive intake of food and junks, food that can add to his or her body weight should be minimized. And we should also advise that he can also see a dietitian who can now look at whatever he has been eating all this while to help plan a regimen of food that he can eat to help cut down his weight. But regular exercises, regular short walks around the house, and reduction in alcohol intake can also help him in the control of his body weight. And also with proper diet control, his diabetes can also be reduced too. And we should also encourage that whatever he does, regular walk, especially in the early hours of the day, will also help in cutting down his body weight. When he does this for the next 1 or 2 months, he will experience a lot of relief and a lot of freedom around the area where he's having the pain at the back. Thank you, sir.
All right. Thank you so much, Dr. Udi. Once again, it's quite helpful. Sorry, Mrs. Zulaiha, can you mute yourself? It's synchronizing and the echo is disturbing. Please. I think she's not paying attention. She just opened it and left. Zulaiha?
Sorry, I'm having issue with my app, so I can't unmute myself. I need to log out,
Okay, you
and I'm
cannot
having
mute it.
Yes, I'm having difficulty with my phone. I'm actually having difficulty with my phone, so maybe I'll try and restart my phone. Let me just restart. Sorry.
Okay.
All right.
Okay, good. Thank you. Now we mentioned that there are other comorbidities in terms of hypertension, obesity. Dr. Udi added diabetes because they all go hand in hand, all these three metabolic syndromes. Now, we mentioned, for instance, he recommended that the patient should be on a low salt calorie to reduce hypertension. You also need to reduce the quantity of your food, the type of the food, and the duration, the time at which you eat. All this will help reduce obesity as well as, reduce the risk or reduce the blood sugar as well. He also mentioned exercises and all that. So the principle of beneficence here is you as a physiotherapist, you're not a dietitian. You're not, an endocrinologist, but you putting all this together with the pain of just ensuring your patient gets the best. You have to go deep down to look for what are the type of food, how you must avoid oily food, salty food, avoid junks, carbonated drinks, alcohol, and all that. You have to put all this education, you have to put about all this information together just for the what? Benefit of the patient. So this is what we call the principle of beneficence. I hope we're moving together, please.
Yes, sir.
Yes, sir.
Are we happy with the rate? Are we happy with the rate we're moving? Can we continue like this?
Yes, sir.
Okay, thank you so much. So let's move to another
Yes,
principle. We see now, okay, I also highlighted some ethical issues myself. I said we should see that the treatment plan that this the physiotherapist is giving is aimed to promote Mr. James' overall well-being. We see we're both addressing, apart from the back pain, we also address the broader health issues in terms of hypertension, diabetes, obesity. All these will put them in the same perspective. We're not just looking at the case of I have back pain only and he presented that to us. We're looking far away from that. And of course, we're also trying to ensure that the treatment we're giving does not cause any harm to Mr. James, because we know that Mr. James is hypertensive and then is also obese. So with that, whatever treatment we're giving will cause no harm. We also try to respect Mr. James' preferences in terms of whatever type of treatment he would prefer. For instance, if Mr. James will tell us he likes to eat, say a burger, or he likes oily foods. We understand you like oily foods, but we could tell you maybe you should eat those things in the morning so that the calorie can be burnt before evening. Of course, we will have explained all the risks involved with eating that, but we still respect your decision that you want it. So we can advise you that don't eat oily food and sleep. They stay in your blood vessels, they don't get burned out, So, and of course, knowing that he's hypertensive and others, we will have to work with other health colleagues to be able to give James the comprehensive care. Don't forget that it's a medical doctor that sent James to the physiotherapist. The physiotherapists also have the mandate to send Mr. James if he feels he needed to see the endocrinologist or if he feels to see the dietitian and all that. So we need to have a teamwork to just to get Mr. James the best of all treatment that he will require. So let's look at the principle of non-maleficence. In the principle of non-maleficence, the most important thing we're trying to do here is that we should do no harm. I believe every one of us as physiotherapists has heard of these excuse me, sorry. You must have heard of this golden rule that we say, do no harm. It means if you cannot help the patient, don't add to their problems. For instance, the same Mr. James who has chronic low back pain, now you heard about acupuncture, and then you have not gone through the acupuncture training. You have not understood how acupuncture works. And then because Mr. James mentioned it, or because you just felt you want to use it, and then you started the patient on acupuncture, and the patient blood pressure just fired up because, you know, when you put a needle in somebody's skin, oh, somebody is there. Can you unmute yourself for us, please? Okay, thank you. So what I'm trying to say here is we have this principle of do no harm. And I believe it's a principle that as physiotherapists, every one of us understand that. But sometimes we don't know when we practice it. I just give an example that the same patient we saw his case in beneficence, that he is having a chronic low back pain, and then you just chose as the physiotherapist to use acupuncture. And this acupuncture, you don't understand maybe the risks and benefits and all that, forgetting that it is not only hypertension the patient has, it's not only back pain, the patient has you know, an underlying hypertension. And don't forget, when you prick the acupuncture needle into somebody's skin for the first time, it's likely going to react with the flight and fly hormones. So in doing that, the blood pressure is likely to increase. So somebody who is hypertensive and you give acupuncture needle and you push the blood pressure up, you see, you have harmed the patient. So we must try to give every commitment to avoid a harm to our patients. So in every way, in every ramification that you know an intervention is likely going to harm a patient, please and please, you have to avoid it. At the same time, we must be able to identify and also mitigate any potential harm. For instance, if you're treating your patient and this patient, you know, is still being under the influence of alcohol, you know that this has the potential of harming the patient. It's not your treatment that will harm the patient, but the patient being under the influence of alcohol can put him into harm. Such type of patient must be restricted from movement. Such type of patient must be held to account. You know, you must find a means of inviting the hospital policy, the hospital securities, the hospital management to come and give the aid that is needed for this patient. So please, whatever a potential that may harm the patient must be taken care of. I'm bringing this just as a case scenario. Sometimes the harm is just inside the department. One of the potential harms we can get in our department is, for instance, your department is not well lighted. There's no lights along the corridors. There's no light in your treatment room. The light is not well, is not comfortable. The treatment rooms or the treatment couches are not strong enough. A patient falling down from the couch. So you should be able to identify anything that can cause a potential harm. Sometimes those things are just right in front of you, but because we don't give, it's not your own, you don't pay attention. Sometimes it's just the slippery floor. You can imagine a stroke patient that you want to bring in for rehabilitation, and then the floor is slippery. So that could be a potential harm. And these days, you find out some people are making a gym that has tiles. How do you make a gym with a tile? That's going to be very disastrous. So please, we must understand any harm that is coming so that we mitigate it before it occurs. Of course, we should be able to assess and address potential risks in every treatment plan we want to give a patient. Now let's also, I wanted us to come up with a case example that we have to adjust the treatment to prevent aggravating the patient condition. Can any person give me a case that we want to prevent aggravating the patient condition? Has any person come through any case that you were able to adjust your treatment so that you don't aggravate the patient condition? I've been giving you cases. I want you to come up with one case. Yes, please. Please feel free. I want us to interact as much as possible. That's, you know, it is not a clinical presentation. It's just for us to understand how our ethics, they work in with us in our everyday clinic. Yes, perhaps maybe I should start calling our names. Mrs. Daobi, you want to say something? Adeni Fowe. Amatukur. Are you all there? Are we all there?
Hello.
Yeah, you are there.
So, is that Mr. Audi?
Yes, sir.
Mr. Audi, I want you to hold on. I want either Adaobi or someone else to speak for now. I also mentioned Adeni Fowe. Yes, please.
Yes, I'm the one speaking.
Fowe.
Yes.
Okay, please go ahead.
Yeah, I think I thought you want to give us an example of non-maleficence.
Yes, I held it to myself that let me hear from you. Have you had a situation where you're treating a patient and then you needed to adjust the treatment so that you don't aggravate the patient's symptoms? Have you? I want to hear your experience.
Yes, of course. In case of let's take of an acute condition.
Yes, please.
Of a low back pain.
Okay.
You know that you first of all reduce the pain before you go into giving exercises. Okay. So you don't want to give exercises immediately. You want to alleviate the level of pain, bring down the level of pain before you go into exercises. So you don't just go into exercises that can aggravate the level of pain for the patient. So you don't want to go step by step.
Okay, you had a case of an acute low back pain condition, right?
Yes.
Now, you also understand that with acute low back pain, you shouldn't just give them exercise. You should do some other modalities that would reduce pain before you start with exercise.
Before you start yes.
The exercise.
Before, if you go directly to giving active exercises, it could
yes,
aggravate the level of pain.
Okay.
So
now,
and that is
for you, what you did when you had the acute case, you know at the back of your mind that if I go ahead to start with exercise, my patient is likely to have more pain than let me start by reducing the pain, like using TENS, ultrasound, and others.
Exactly.
So what did you do?
Exactly. Of cryotherapy. Use cryotherapy.
Okay, cryotherapy. Okay. Let's assume you, but that is part of your treatment regimen. You did not adjust it. We're looking at adjustment in terms of this is what you have been giving to this patient, right? But you found out that this patient, instead of reducing the pain, you are increasing the pain based on your treatment plan.
Yes.
Do you understand me?
Yes. Exactly. That is what I was saying. That if you go into
I hope you have not lost me.
Okay. Exercises And then the patient came back the other time, and then told you that the level of pain increased, and he was able to sleep through the night. You know that, okay, you have to stop.
I don't know, am I the one losing him, or it's me that you can hear me?
Okay.
Let
me understand you. Let me understand you.
No, I was just asking other colleagues, is it me that is losing you, or everybody is losing you while you speak?
Okay, maybe it's the network.
Yes.
We can hear him clearly, sir.
We can hear you now. Just go ahead.
Yes, I said if you have an acute condition of low back pain, and maybe the physiotherapist started with maybe included active exercises.
Yes.
And then the patient came back with more pain. We can change our mode of treatment by going into, first of all, tackling the level of pain by giving cryotherapy, graduating to infrared therapy. Make sure you reduce the level of pain before you now go into exercises.
Yes. Well, that's very correct. Yes, I understood you perfectly. I'm trying to look at it from an angle. You know, sometimes in back pain scenario, let's understand, if you treat a patient and then the pain got worse, it doesn't mean it's a harm. That's where I'm trying to go here.
Can I chime in, sir? Can I give
do you get my point? For instance, a patient presented with back pain with radiculopathy, you're able to take away the radiculopathy from, say, the back of the thigh to the back, and then the pain in the back increased times 2. It doesn't mean you have harmed the patient. In fact, you have done more good than harm. Yes, Eniola decides you want to say something. Please go ahead.
Yeah. Hello, sir. Can you hear me, sir?
Yes, we can hear you.
All right. So because you asked for a scenario, if anyone has had to change treatment plan because maybe a patient felt they were not getting better or they felt more pain. Yeah. So at the time I had a patient with low back pain, had complaints of low back pain, and the first time she came, she felt relief, or the first few sessions she felt relieved. And then as the session continued, she categorically was mentioning that some particular exercises were causing more, that each time she goes back home, maybe the rest of the week or for like 4 days, 5 days, she would be feeling lots of pain. So like there were some particular interventions that she sort of noted was causing her more pain. Right. Exactly. So in that case, I then advise, or I then
so actually those are the kind of scenarios we're looking at. Go ahead, please.
Okay, all right. So I then thought that she was thank God that she was even able to identify those particular exercises that she was that was aggravating her pain. Then we stopped it for that time, and then we then picked up some other interventions that she. In fact, at some point she said the pressure of massage, which to me I felt wasn't so much. The pressure of massage was causing her more pain. So at some point we have to take out massage for a while and do some other things.
Yeah. Yes, I think thank you so much, Eniola. Those are the issues we're trying to see how we can raise from malfeasance. That is, any treatment you want to give to the patient, and then that treatment is trying to cause more harm than good, such treatment has to be modified. You need to readjust the treatment, and it's definitely going to be one of the major things that will tell the prognosis of your job. Are you really getting it, or you are not getting it? So if you're not getting the aim and goals of your treatment, then you just need to readjust, review your treatment, and then change it. There is no harm in changing, because the idea is that you want to work in the best interest of the patient. So you won't say because you have written that these are the things that has to be done and you will have to do it. So please, let's understand that as well. Now let's look at the principle of justice and fairness. I said in the principle of justice, we need to be fair and equitable to treatment. It is, we must ensure that all patients receive fair access to care. This is where some of the problems come in. Let me give us this scenario. If, for instance, we have a clinic, and then that day, the chief medical director of our hospital happened to visit our clinic. Are you guys with me?
Yes, sir.
Yes, if we have the CMD in our clinic, and then the CMD presented with back pain, let's assume we're treating our CMD for chronic low back pain. The treatment that I will give to the CMD, is it going to be the same treatment I will give to any other patient in the clinic? Ladies and gentlemen.
Yes, I believe all patients are equal, irrespective of the patient.
Is that Eze?
Yes.
Yes, Stanislaus. Is that Stanislaus? I hope I'm pronouncing it well.
Stanislaus.
Stanislaus. Are you sure you're not from the Greek? Is it? That's a Greek name. Anyway, welcome on board. Now, I don't really want to accept that your point. Dr. Eze, which clinic are you working? Hello.
Hello. Okay,
Eze,
currently,
yes.
Yeah, yes. I just finished service.
Okay. I can see, I can accept and recognize your innocence. I appreciate that. Please, where is Okoye?
Hello.
Augustine Okoye. Augustine, on mic, unmute your mic. Dr. Okoye. I hope he just didn't drop it and leave too. Yes. Akinya Harry, are you there? Harry?
Yes, thank you. Can you hear me?
I can hear you. Please go ahead. Sorry, is that Eniola speaking?
Yeah, Akinya speaking.
Akinya, okay, Akinya, please go ahead. Eniola, I'll get back to you.
We are supposed to give the same treatment.
We are supposed to.
We are supposed to, but normally,
I like that.
the Nigerian factor, we don't usually do it. The way we see the family, we introduce finish, we introduce a lot of caution, we give VIP treatment, we call it VIP treatment.
We bring in even equipment that the CMD did not buy into the hospital.
I've never used before, that we may not have given to any other person before.
Now
Yeah,
imagine that the Senate president was in your clinic.
Yes.
Is it still going to be the same?
No. So there are VIP treatment, commoners treatment, and so on and so on. It's not supposed to be like that, but we do it in Nigeria.
Okay, so because that's what we do. Eniola, okay, go ahead, please. Eniola, you want to say something?
Yeah, he said it all. We want to go the extra for the CMD or for a special person in court.
All right. I think Okoye is up with us. Okoye, you wanted to say something too?
Sir, based on what you are saying,
yes,
we normally give preference treatment to our
preferential treatment.
Yes, preferential treatment.
So So now this is where I'm saying we are breaching the principle of ethics in healthcare. Yeah, Zulaiha, your hand is up. You want to say something?
Yes, actually.
Yes,
I just wanted to reiterate with what the first speaker said. Normally, in practice, we're supposed to treat patients all equally, but in field, that's what we've been taught in school. But when you come to practice, it's a different ball game. It's a different ball game when you have someone of high-ranking status coming into your clinic. You make sure everything is working optimal. You make sure you have, even if you don't have sanitizer, that's the department will have sanitizer. Even if you don't have, maybe let's say, for example, we're supposed to have water dispensers in our clinic.
The bed lining.
But that
you know there are no bed sheets. That day they'll bring you
yes, they'll give you disposable bed sheets. But I happen to work in a setting whereby we provide services that are equal to patients, irrespective of your cadre, whether you're from a high-ranking government official or you're a cleaner. I work in a setting whereby we give that optimal service, and we're trying to keep it at that level.
Well, thank you so much. We're going to appreciate your setting. I hope we'll be there also to see these things vividly. Of course, Nigerian factor. Where is it?
It's in Abuja.
Abuja. Is that the State House Clinic?
No. I work at 2 centers where it's, I think, neuromuscular rehabilitation center. And we're trying to build up another facility where I'm heading, Bayes University Hospital. So it's...
Oh, that's beautiful. That's beautiful.
Yes.
Bayes is already having a clinic now? Oh, great.
Yes, we're setting up. We're setting it up. So I happen to be the person in charge. So when I'm bringing in what I learned from my other clinic to Bayes University, we're trying to give, irrespective whether it's a cleaner, whether you're a government official, you're going to be treated equally. You have the same right because you're paying money for services.
Yes.
And which is supposed to be. But in a normal setting, we all know that it doesn't happen.
All right. I'm happy we are following. I decided to wake up all our attention. That was why I wanted to post it, that everybody must speak. Now, the point here is, sorry, okay, somebody wants to say something? Udi, okay, yes, I think I have held your hand for some time. Go ahead.
I think we have said all that we needed.
I didn't know.
Chooks, please mute yourself. Chooks, can you mute yourself? Udi has the floor.
So,
go ahead.
I didn't know.
Udi, your network is very bad. We can hardly hear you.
Can you hear me now? Okay. Can you hear me now?
Yes, we can hear you. Go ahead.
Yes, I was trying to say that it is by human nature. When people of caliber comes to us, we are constrained to do certain things for them because of their position in society. That cannot be ruled out. Even do that. In an environment where culture and respect is brought to high, is taken high esteem, we cannot overrule that factor. But you see, in trying to respect the high and mighty, when they come to us, we should still treat them the way we are supposed to treat them professionally. When we treat them the way we are supposed to treat them professionally, they will also understand that we are not doing eye service. We are not over treating them, because even though they are laymen in what we do for them, by simply observing our body language, by simply observing the way we do our things, at the end of it all, they have an impression that we are trying to just please them and not actually treat them well. So, but if we respect them the way we should respect them as high caliber society men or politicians, but in respecting them, we still treat them in the best way we can. They will be able to separate both and be able to respect us for what we do. But having said that, that doesn't mean when people that are of the lower that come to us, we treat them shabbily. We're supposed to be guided by the principle of fairness, whatever we do. And when we do that, even though those that come from down the ladder, as we treat them also, they also identify that they are giving them the best treatment. The best thing is that we should put humanity in the way we treat our patients. Once we do that, then we will not cross the line in our practice. Thank you, everybody.
Well, thank you so much, Dr. Uti. You have really stressed another point that was not raised before, that knowing our culture and tradition as well as beliefs, we also have that tradition of respecting. Yes, boy in there, I'm coming to you. I've seen your hand up now. I'm coming. I've seen your hand. I just want to also look at the angle where Udi raised now, saying by our culture and tradition, we're expected to respect. So is it when you respect an elder or people that are in a position, does it mean we should give a treatment to them in which another person who is not in that level or who requires the same treatment will not get that treatment? This is where we're talking about fairness. Sorry, yes, boy, go ahead.
In fairness.
Thank you very much. Well, I see it in another, from another perspective. I think when we have maybe highly placed individuals like that, it should be an opportunity for us to even use that occasion to negotiate for better facility about yes, maybe like
we don't have this, we don't have that, and then they should be able to provide it.
Yes, because sometimes ago in Jos University Teaching Hospital, many years ago, I think around 1981, the CMD there went overseas for treatment for low back pain, and they asked him that you say you are CMD of a teaching hospital, you should be able to get rapid department and all these things. He was not aware. So by the time he came back, he phoned the person in charge of the department, and they said, "Do you have he first of all find out whether they have department, what or shortwave, this and that." He said they don't have anything. Within 2 weeks, they got that equipment. Within 2 weeks. Because of his use. So I don't subscribe to the situation where you carry your own personal equipment to go and treat them. If they don't have the equipment in the department, then use that occasion to get that equipment. Then another aspect is that if you know that your treatment will take up to maybe 45 minutes and so on to be effective on a patient, and just because it's a low cadence, you use just 10-15 minutes, and you are using about 1 hour for the early place. You are not being sincere. You are not being, So anything we can do,
and justice.
Yes, anything we can do that we make the patient to benefit very well, you should be able to go ahead and do it. That's my own concern.
Yes, thank you so much. I appreciate your yes, please.
I have some contribution to make concerning this.
Okay, go ahead.
I want to certainly appreciate you for this presentation. I experienced something in the issue of friends just
Mr. Sunday, your network is not good. We can't hear you. The line is breaking off. I don't know if you're supposed to move to a better side. The line is breaking off. We can't hear you.
Okay. Can you hear me?
We still cannot hear you. I would suggest you change your network, and then maybe you reach out to us again as we move.
I'll be happy to challenge.
I don't know, maybe it's raining in your area. Okay, I think when you have a better time, we'll still take you back. I really want us to see how we can finish this by 12:30, and then we come back, we go for a break. Please, let's see how we quickly finish this aspect. We've understood what the fairness and justice is all about. We want to ensure all our patients receive fair access to care. So what we're trying to say here is, if I have to spend based on, evidence-based practice, that infrared has to stay on a patient for 20 or 30 minutes for it to give its maximal effect, or the use of TENS. But because this person is no cater person or from a rural area, I can just give him 10 minutes and say, okay, we are finished. Or I will just give him once in a week treatment, or once in 2 weeks treatment. Whereby if I have a highly placed patient, I say, oh no, you can come in on daily basis. So this is really an unfair treatment to everyone. So we're trying to say you must give fair treatment. The access to care every patient must receive a fair and equitable treatment. If this person is also going to come once in a week, then the others will come once in a week. If you have the opportunity for 3 times in a week, this one too should come thrice in a week. So like Zulaiha has said, she's trying to put up this type of services, which is going to be based on fairness and justice for all. So this is a principle that we must all try to uphold in our lives, daily lives, as well as our professional life. Now, in doing this, there is a major issue we need to look into, which is about distribution or distributive justice in healthcare resources. We all know that healthcare resources are usually limited or limited available resources. The healthcare resources that are available are usually limited. So for instance, we will have something we want to give out, but where and how do we give out? Let me give us an example. During the COVID-19 pandemic, you remember when they started distribution of the COVID-19 vaccines? We in the Africa, did we get? Hello? Hello?
We didn't get our own consignment.
So we didn't get our consignment, but they kept giving it out to the Europeans and international community. Now, this is also where justice has been trampled upon in healthcare. And now when we Africans stood up to start producing our vaccines, those guys over there refused to accept it, claiming it's not effective. It's not. Did any person try their own it's effective? Was there any trial on their vaccine? So, but these are where justice and fairness are not allowed to be distributed equally. I said distributive justice is a fundamental ethical principle in healthcare. It aims to ensure fair and equitable access to medical resources and services. Distributive justice refers to the ethical principle concerned with fair and equitable distribution of resources among members of the society. That is, every person must have fairness and equitable distribution. We say it emphasizes the fair allocation of medical resources, services, and opportunities to ensure all individuals have access to necessary care that they want. Distribution of this justice ensures that healthcare resources are allocated based on the need. That is, who needs it most? We should be based on equity. That is, who are those that are in, you're not going to say because we have given the United States $10 million worth, the Africans has to be given 10 million. No, that's not equity. If the people who needs it in Africa require $100 million own, it's the same. That's what you will give, because that is when the principle of equity will play. It's not equality now, it's about equity. So, and it's about need as well as fairness. So we should not distribute or allocate resources based on socioeconomic status, geographical location, or based on personal connections. We all know personal connection is one of the key factors that happen in Nigeria. If you are one of the CEOs now and you want your budget to be passed, you know, for your facilities to be upgraded or for facilities to have things in healthcare, you must know somebody who knows somebody who knows somebody. So that is not fair, or that's not fairness and justice to healthcare. I said, if you have a distributive justice in your distribution, it will promote, in fact, social justice. It is among the society. Everybody will feel important. Everybody will feel carried along because it will address the health disparity. And then it will encourage working together towards equity for all. So these are things we want to ensure when we take up the principle of justice and fairness. Now let's look at the principles that guide distributive justice. Now we want to distribute our limited available resources. How do we do it? I said we have to look at those things I mentioned now. Equity, which is about providing care that meets specific needs of individuals, recognizing that different people have different healthcare needs. For instance, in the villages that are suffering from cholera, they may not be interested in your COVID-19 vaccine, but they are interested in cholera. So even if the cholera vaccine is 100 times costlier than this, that is what they need. So for you to give them their healthcare need is what is called equity. Now we also have to look at the prioritization of resources. Now, instead of you bringing about giving, budgeting for hypertension and diabetes, as at when there is infectious disease that is communicable in a society, then you will know that the need of this supersede non-communicable, and then we'll have to pay attention to that one and support that healthcare need. And of course, equality also comes to play when we ensure that there is equal access to healthcare for every individual. Everybody has the same opportunity to visit the same clinic and to be seen in the same way. The proportionality we're talking about is also, it depends on the severity of the condition. For instance, a patient presents in your hospital with a case of diabetic foot with somebody who presents with obesity. This guy with diabetic foot, if he's not given the right resources, is going to lose the limb. But the patient with obesity could take more time for you to work on him to be better. So you see that the proportion of those who need this thing, we have limited fund, we can only take care of 1 or 2 patients. So that patient we're going to give the fund is the one with the highest and severe situation at that point in time. So this is what we're looking at, proportionality. So in trying to do all this, there are challenges that we have to face in achieving distributive justice. Number one is that most of our resources are scarce. So since there's a limited availability, so it means whatever that is available, it cannot go across board. So that principle of equity, equality, affordability, proportionality, as well as equality will have to come to play. Who do we give what, and who do we give low? So this has to play a role. Of course, there are also geographical barriers. We understand that there's already disparity between those living in urban areas and those that are living in in rural areas. In the urban areas, you have both. You can see in urban area, you have what you call the primary healthcare, the secondary healthcare, and tertiary healthcare. So all these systems are already in place. But in the rural area, you only find where you can only have where you can only call the primary healthcare. So now already by the geographic of this place, you already have disparities in how healthcare services will be allocated. So therefore, it's a huge challenge now to tell us that if you don't use the distributive justice, people will not get what they really want at that point. Of course, you have the economy of inequality, because differences in individuals' ability to afford healthcare services and treatment, it differs across board. Like what we mentioned, if, for instance, there is no fixed amount of money for each services in a clinic, when you come to somebody's clinic, and he sees that you're giving them a lot of money, they will pay more attention to you than somebody who comes and give less money. And this is where you're going to be having challenges in how to give justice and fairness in the treatment you are distributing. Of course, we also have issues that revolves around policy and systemic issues. That is, there are problems that are born in the system, at the healthcare system itself. For instance, don't forget, most of our teaching hospitals are all being run by medical doctors. The CMDs are medical doctors. Now, when you have any allocation that is coming, or budgetary allocation or resources, you find out that the medical doctor wants to give attention to his medical doctor colleagues than every other person in the hospital. Now, already the system has created an inefficiency and inequality within the healthcare system. All these policies are things that are standing as challenges and barriers that we need to work upon for us to break the issue of, for us to be able to achieve that distributive justice in healthcare. Now let's look at a case study. I brought these examples for us to see, especially like how all this distribution of justice can happen locally, nationally, and internationally. For instance, during the pandemic, you receive that allocation of vaccines and medical supplies during the COVID-19 pandemic. Even your hand glove, that is what we call the PPEs, you know, the personal, what do we call it? Personal protective equipment. You find out that they will give the medical doctor more, and even for you as a physiotherapist, you struggle to get one. But you will realize that sometimes you even have to hold, drag, lift, and carry your patient. But still, nobody is saying your health also needs to be protected. They just keep calling upon the doctors. So these are issues that already are also a problem in allocating of these resources. It's the same thing we mentioned when the vaccines could not even get to everybody. You remember when people have to be paying to get COVID-19 vaccine. So all these are issues that has to do with distribution of justice. You look at the rural healthcare programs, you find that most of the initiatives that want to improve healthcare access in rural areas through mobile clinics, telehealth service incentive, they don't give the necessary individuals. When there is allocation of budget and money, the medical doctors and those who are in high positions will capture it, but they cannot go and live in those rural communities. So you find that they cannot train even people from that community that will serve them. They are only interested in the cash, so they get the cash and they cannot still give the services at those places. We have also systemic issues like the health insurance reform. When health insurance came, up till today, you find out that physiotherapy, payment for physiotherapy in NHIS is about just 1,500 naira. So how many healthcare facilities will accept that to run what do you call it? An insurance for somebody with 1.5 per session, where they know people pay as much as 20,000 naira per session outside. So those policies are not helping to take care of all these inequalities, as well as justice to and fairness to the system. So all these are issues we're looking at. So therefore, in ethics, we have to consider how do we balance individual needs with collective welfare, that ensuring that resource allocation decisions are transparent and based on ethical principles. It is, let's all come together, agree on how, based on those principles of fairness and justice, you know, based on distributive justice, how do we balance these things? We need to discuss it together. And of course, we should be able to address the biases and the systemic inequalities that affect fair distribution of resources. This is all we're talking about, the principle of justice, how the allocation, healthcare allocation will be distributed equally in town. It's already 12, I'm trying to rush. Maybe we'll look at our group distribution before we go out. Now, so let's rush into fidelity. Fidelity refers to the principle of being faithful and loyal to commitment and responsibility. It is that principle that entrusts a patient's health into your hand. It involves maintaining the trust and confidentiality, which is inbuilt between the patient and the therapist. It is that PT relationship. Fidelity encompasses being, as a physiotherapist, you should be dependable. The patient can depend on you. The patient, you are trustworthy, and then you are following through on promises made to patient. So they should not find you wanting. I've seen a situation in my one sector where there's an interaction between a patient and a therapist, and then the therapist, scammed the patient of over 3 million naira. It was mad when the patient came to me. It was, talking about this in the clinic. What professionalism is left in such type of a patient, a PT? So that's worrisome. Now, what's the importance of fidelity in healthcare? I said, number one, it builds trust. It fosters trust between the patient and the healthcare provider, which is essential for effective therapeutic relationship. If I don't, trust you, whatever you're doing, it means I look at it as something that is, it's not worth it. I feel you're going to harm me, so I will not pay attention to it. Of course, when there's fidelity, it encourages consistency in care. Because when I trust you, I still want to follow up with you, whatever that you're doing. And whatever you give me as, for instance, like a home program or whatever recommendation you make, I trust your decisions, I believe in them, I'm likely going to follow them. And of course, it ensures the patient's safety. Because when there is fidelity, you are also very concerned about protecting, and you are very vigilant. And then you are committed to providing high quality care for this patient. You don't want anything to fail. Now let's look at some examples of fidelity in practice. Number one is confidentiality. We all know that you are not allowed to give out the information of any patient to any person outside the healthcare, even inside the healthcare, as long as he's not responsible or has anything to do with that patient. I take an example of a HIV patient. If the file of that patient comes to your hand and you needed to treat the patient, you will see the patient file is tagged, maybe RVD, maybe they give it different type of acronym just for the healthcare to be conscious that this patient is like this. Now, the confidentiality is now in your hands to be sure that you don't give out that information anywhere, except to only those that will benefit the patient. Now, let me ask you this question. If you recognize a patient, if you recognize that there is a patient that is going through, a patient has HIV, the file came to your hand, and you know the patient is HIV positive. Now, somehow you get to understand that that patient who is HIV positive wants to get married to another lady who you know is not HIV positive. What are you going to do based on the principle of confidentiality? That are you going to allow that marriage to go on? For instance, they did not bother to check themselves to do their test, but as a healthcare provider that this patient is HIV positive and this is not. What would you do? Yes, please.
By virtues of ethical principle.
Yes.
By virtue of the ethical principles.
Mr. Sunday, we still cannot hear you at all. We're not hearing you at all. Your phone is just resonating. We're not hearing anything. Dr. Udi, can you go ahead? Mr. Sunday, please, you have to be patient. Your phone is not going through. We can't hear you at all.
I will advise,
Mr. Udi, please.
I will advise both couples to go and do all the basic medical tests required. Because most of the
you are going to advise.
Yes, both parties, the bride and the groom, ensure that before the marriage is contracted, that they should ensure that they do the basic test before they go ahead with the marriage. And I will explain that it is part of the obligations that they owe themselves as couples, that basic tests that they ought to do, they should do them before the marriage is contracted formally. Thank you.
Now, in a culture or a tradition whereby, nobody care to listen to what you have said, and then they want to still go ahead to do that marriage, what will you do? Because they have not had your reason for saying all this.
Because
they should go and do it's something they have to do and all that. They just listen to you and say, okay, we have heard.
Since I've given them my advice and they want to go ahead, what I will do is, marriage is an obligation that when you get into whatever comes with it, you have to bear the consequence of it. So I will ensure, because I have an information that I can't disclose to the other party involved in marriage because of my confidentiality that I have with the person that I have this information of. So all I will say is, if they still go ahead with the marriage, whatever comes out of it, then we can now go ahead and administer the normal routine advice that we normally give couples that have issues. I will advise them that when the marriage is,
listen to you that you are going to advise. I'm telling you, they have listened, they have had your advice, but they refuse to do the test. He wants to go on. You can imagine when a man has that situation, he knows what is wrong with him, but he wants to hide it. I've seen Emmanuel Okoye. You are welcome on board. I've not seen you before. Yes, what do you want to say about this?
I will just allow them to have their way, even though I will have that burden of
yes. We have listened to your point. Emmanuel Okoye, are you with us? I need you to unmute. Emmanuel, I'm sure. Did you just put it on and left? Okay, Ogule, are you there? Ibironke? I want us to look at it from 3 cultural perspectives. Ibironke? I hope some of us are not just muting and then dropping the phone somewhere.
Yeah,
that's why I have to be, hand picking.
I hear,
okay,
Prof.
Let's say, yes, please. Who is there?
Well, sir, from my own perspective,
just assuring you that we're here. We can hear you well.
Okay, thank you so much. Yes, go ahead.
Yeah, sir, from my own perspective, yes. I will go in as when I've advised and they've refused as a medical practitioner to go for the test.
Yes.
Hello,
the one that is since I know both of them, I will inform the one that is negative of the situation, because in this case we are dealing with, it's not about one individual.
Yes,
it will come down to the children, and at the end, it will be part of the community. So when the complication the consequences that will arise from you being quiet just because of one person will be disastrous.
Well, Fatima, at this point, we're not looking at the person. We're looking at the principle of confidentiality and now for the principle of what? Saving life. Which one are we going to take? So these are the ethical dilemma that we'll have to deal with. On the one hand, the man knows he's HIV positive and he has refused to make it known to the partner, So are we supposed to, as healthcare providers, are we supposed to keep the confidentiality to harm another person? Fatima Alilu is raising a hand. Yes. Oguleye, I hope you are ready.
Yes, sir. Yes, sir.
Okay, let me listen to Fatima. Fatima.
Sir, as the previous speaker mentioned, yes. In this case, the principle of do no harm trumps the principle of confidentiality or fidelity, because we're not talking just about one person, but the partner and the community at large. So the partner needs to be informed, and whatever decision that is being made, it needs to be of free will, and at the same time, options should be explored in such a way that it would prevent further spread within the community, let's say children and all of that. But the healthcare worker does not keep it in. It should not be.
I appreciate your position, but I want you to be aware that it is the HIV patient that that comes to you. The partner is not your patient. Okay? So do you still have an obligation to protect her?
So as a healthcare worker, you have an obligation, I think.
Okay, this
is something.
I've understood. Don't worry.
It's similar to something like COVID or something. So
yes,
it's good to inform.
Yes. Okay.
You would ask the patient to bring in the partner.
We're going to expand more of your discussion. I want to listen to Okuleye. Okuleye, yes. What's your take on this?
Thank you, sir. Good afternoon, sir.
You're welcome on board.
Thank you, sir. Well, within the confines of the legality of the case.
Yes, please.
I do not think I have the obligation to tell the wife. Because the wife to be.
Yes.
Within the confines of the legal laws, the laws of the land, I do not think I have that obligation. However, as a healthcare provider,
yes,
the onus lies on me.
Yes.
To be able to prevent complications that can ensue from such marriage, if consummated. Yes. So in my own interest and in the interest of the society at large,
yes,
I will counsel my own clients.
Yes.
I will counsel him. I will give him reasons why he should tell the wife to be.
He must be able to divulge his status to his partner.
Yes, that is all I can do. And I can go further to give him examples of those that did that and were able to protect themselves.
Yes, and protect the baby and the community.
Exactly. That's all I can do.
Thank you so much. Thank you so much. We appreciate your point. And your hand has been up. You want to say something?
Yes, sir. So what I wanted to say was what the speaker, the person that just spoke, mentioned.
Yes,
encouraging the person with the diagnosis, since he claims to love the woman, encourage him that if she loves you in return and she can cope with your diagnosis, that there are lots of interventions in medicine that can make both couple living with HIV to not transfer to children, but not me as a medical practitioner tell the couple that is not aware of that, it will be to breach the ethical rule of confidentiality in a very big way, right? And it could even break the marriage that is about to be formed.
All right, thank you so much. That's true. Tim, you wanted to say something?
Yeah, I think my point has been covered. When it comes to ethical issues, it's controversial. That's why we see some of our colleagues saying that.
You see, that's why I appreciated the Ogunleye's point. Ogunleye came up with issues that has to do with legality. So your ethics is there, and of course you must have your ethics must follow the legality of the state. And if you look at places like America, every state in America has its own code of conduct and ethics of practice. So it means whatever you want to do must fall within the law of that place.
I have a question, sir.
Okay, we have to. I'm sorry.
Please, I have a question too.
And
I have a question.
I'm coming. Eze and Adeni, I've seen your hand. We'll be taking your point. Let's take the question first. Yes, please.
Okay, so what if the wife to be is the medical practitioner's family member?
It's irrespective of whoever is the wife. You have an obligation to try to protect people in the society. So whether you know the wife or you don't even know the wife, you are only supposed to go seek for that wife. Because as far as you've heard that this man wants to get married, your concern is that person he wants to get married, is she also an HIV positive person? In fact, you want to find out, because until you find out she's HIV positive, you will not rest. Now you found out that person is not HIV positive. Do you have a place to sleep again? So this is where we're going to. So you can imagine, and it's somebody that is close to you. That's more terrible situation for you now. So you're looking at it now that in our culture, this is my sister, brother, or my auntie's daughter or something. And I know that this man that wants to marry this lady is HIV positive. I have to go and say it. So we're now saying, which rule are you going to use in terms of confidentiality, as well as the rule of what? The right to protect life. So we looked at Ogunleye's position, that we have to look at it within the ramification of the law. What is our law about HIV stigmatization and others? What is it talking about in Nigeria? So if we assume there are no laws, we just want to look at medical and ethics. I said you have two dilemmas now. The dilemma of confidentiality of this your patient, and of course the dilemma of protecting the society. So what do you do is what we're asking for. Yes, Ibironke is up again, but let me take Adeni first. Oluwafunmilayo, go ahead.
Well done, sir. So my own contribution is
actually like there's a device close to you.
Yes, can you hear me, sir?
We can hear you now.
Okay. So I said that I think the reason why we have this dilemma is because there's no collaboration between medical services and social services in Nigeria, especially. That's because true. In this kind of case abroad, they have a lot of public health services and social services that will handle this, so that the burden doesn't really fall totally on the healthcare practitioner. So I think even though we are supposed to have a duty of care to maintain confidentiality of our patients, but in the aspect of maybe protecting the public from preventing our patient from transmitting HIV to maybe the wife and the children, there are some services that are supposed to be available for that, so that the burden is not on the healthcare practitioner alone. So I think there should be people that are trained to manage that. I think that's my contribution, sir.
All right, thank you so much. Then he feels we should have the social work. We do have social workers in our clinic. Okay, it's fine. Eze, okay, go ahead, Eze.
Okay, thank you very much.
Yes.
Yes, thank you very much. Just like the last person
just like last person spoke. She mentioned that there are people who
please
decisions.
mute yourself. Your phone is resonating to another thing. Go ahead.
Yes, she mentioned that there's some people that there's some people that such the decisions should fall into. Such as I don't know, they are in people like UK. I think they make use of the safeguarding teams and something like that. I don't know what else they
No, we have in Nigeria our social workers. Those are what they are supposed to be doing.
Yes, but in situations like this, where you are exposed to situations like this, where you know that not revealing this information will actually lead to harm to the partner and also to possibly other members of the community. I think the confidentiality at this point needs to be handled in a way that it doesn't affect you and doesn't affect your profession. That is why it's actually important that you refer to the people who are best trained to handle situations like this. But because there should be a setting
your
where
position
you
is
report
clear.
such.
Dr. Eze, your position is clear. I think we're trying to run out of time. I want us to have a break and then we can come back. We've listened to me. I saw your hand up, Vironke, and then others too. Please just calm down. I will let's finish up this slide and we'll go for a break. We'll come back to complete it. Sorry, sir. Okay, sorry, colleagues. I had to pick a call. I'm sorry. Now we will just be patient. I've seen so many hands on top. I know these are discussions that everybody wants us to clear. We're not looking at how do we measure. Somebody in the background sent a message. He said the emphasis, as far as it's concerned, is ethical and legal necessity. It's ethical, and of course there are legal necessity for us to inform to talk about this to the relationship in health matters. At least we should consult our institutions, ethics committee for guidance. Okay, thank you, Olidami Lola. So Nihi Ola also mentioned that in my opinion, if my establishment has a medical social welfare unit, I will simply refer the case to that unit. Yes, that's great. And of course, Fatima is also having another point here. I think she said, okay, it's Mohammed Salisu Adamu, that, okay, he agreed with the other speakers. Well, most of us have our points and the points are really understood. And I feel we should be able to see how these things work in practice. And that's why I came up with them. Another example in fidelity, you know, we're talking about fidelity. My patients have trusted me. I'm not going to jeopardize this information. Okay. And somebody remember the case of the King of UK, who recently was diagnosed of what do you call it? He was diagnosed of pancreatic cancer. You know, he has a CA prostate. Sorry? I said, can somebody remember the case of the King of England who was recently diagnosed of CA prostate? Somebody is still at the background disturbing.
Okay.
Mr. Temitayo.
My face that used to change.
Temitayo, mute yourself, please.
Okay, sorry.
Aha. And I didn't need you to please mute yourself. So I was trying to ask us that do we remember the issue of the King of England, who was recently diagnosed with CA prostate? And there was a health personnel who has information to his file and was trying to share it in public space of this diagnosis. Do we follow that case? Did anybody remember? It was just like 1 or 2 months ago. That, I think the person was a medical doctor. He almost lost his job because of breach of confidentiality. What did he say? He gave out the information of his diagnosis to the public space when he was not asked to do so. It's not his responsibility. So, but he had to cover up so many things, and then before he was allowed to continue his job. So please, we should understand that confidentiality is key, and then you must understand how to safeguard your patient's information. And of course, your patient must see that you are reliable. That is, they should be able to depend on you, especially in terms of appointment, follow-up treatment, responding to their needs. You cannot give a patient appointment and you are not there. You cannot call a patient that come by 8 and the patient are there by 8 and you are yet to come. So you have to show reliability in what you do. And of course, you should be able to advocate for the best interest of your patient, whatever the patient is likely. In fact, sometimes you need to challenge constitutional authorities just to make sure your patient gets what will help them best. Like I normally say that in our labor unions, we have never gone to strike for once in Nigeria because there are no PPEs. There are no equipment to work. Some physiotherapy departments don't even have anything. I've seen a department whereby it is the staff that put money together to go and buy infrared bulb. So those people will not go on strike because there are no facilities to work. But we go on strike always because our salaries we want it to be increased. So we're not advocating for the patient, in the best interest of the patient. So veracity is also like fidelity. It also refers to the principle of truthfulness and honesty. Veracity involves providing accurate and complete information to patients about their health. I spoke about this when I was giving a similitude or an example of some of our surgeons that they want to do, a decompression surgery. The patient is not given every other alternative, even a medication. They just give the patient a paracetamol so that the pain will force the patient to make a decision for that. So that's really, really a breach of trust in healthcare. So we should be able to be as transparent as possible. And of course, we should avoid how we deceive we misrepresent our patient. Most of this thing comes with deceit. You show the patient that's the only treatment, which is not true. There are other alternative treatments to back pain, not necessary surgery. So it's like you are almost coercing or manipulating the patient to come for your treatment. I said the importance of veracity in healthcare is that it helps to ensure our patients have necessary information that they will use to make informed decisions about their health. Of course, it builds trust and mutual respect between the patient and the caregiver. It also empowers our patients by providing them with truthful information, enabling them to take care or to take active role in their care. So I said the example is when you give clear communication, you provide clear, accurate, and timely information about the diagnosis, treatment option, and potential outcome. That's a very good issue about veracity. I remember it's a very simple one. Veracity that we always say, what is the veracity of your claim? It means you claim something, how truthful is that claim? So it's all about truthful information, accurate information, and then clear information. And it's all about honesty, So you're being honest about medical errors. It means when there's a failure or there's a problem from your side, veracity means you are able to tell the patient, oh, I'm sorry, it's my fault. I didn't do ABCD, I didn't do this well. That's why it happened. I take full responsibility of that problem, okay? And of course, we should learn how to do our disclosure, because when we give full disclosure about relevant information, and sometimes it could even be difficult. For instance, for the first time you want to tell a patient that is HIV positive, you cannot just do the test and bam, you are telling the patient, no. You have to go for over and over confirmation of that test you have to do a CD4 count, you have to do so many things. And then before you now come and sit down with the patient and interact and let the patient understand everything. So please, we're going on break now. But before we go on break, I want us to put ourselves into 3 groups. I have 3 cases which I want us to discuss when we come back from our break. The break is going to be 1 hour as aligned. So we're going to take group 1. They are the ones that will take the first case study. I want us to analyze and discuss the ethical dilemma using the following case studies. So group 1, I need where I can see about 40-something or 50-something people on the group. So maybe we take 15-15 or 20-20. So we have 3 groups. Please, among yourself in the group, just tick which group you want to stay with. Are you going to stay with group 1? Are you staying with group 2 or group 3? You can look at it. You can choose your group based on the case study. So case study 1 is that you want to discuss about informed consent, that a patient refuses a recommended procedure. I want us to discuss about informed consent and autonomy. Okay, everything that has to do with this issue, I want it to be discussed and analyzed. I said this, analyze and discuss the ethical dilemma. Of case 1, which is about informed consent and autonomy. Case 2, conflict of interest and professional boundaries. Well, this case 2, we are going to be discussing professional boundaries fully as we move into our next phase after the break. And then case 3 is resource allocation and justice, which we have discussed. Please put yourself into 3 groups. And then when it's 20 minutes to 2, we'll be coming back for the second phase of the of our presentation or the workshop. Is it good enough like that? Or would you want us to just come back by 2 exactly? This is 20 minutes to 1. I wanted the break to be 1 hour. Guys, what do you think?
I think 1 hour is okay.
Tim, I saw your hand up. You want to say something?
Yes. In terms of choosing a case, so that we don't have a scenario whereby we have more people interested in
one group than the other.
Yeah. So I think
what's
it's
your
just better
suggestion?
that we have 3. We just divide equally. Whatever room you find yourself, whatever case, then you work with the group.
Because it's not in numbers, I would have said, okay, let me just read the name the way it comes in the participant chart. So I have, let me say I'm giving 15-15. We start with Tim, Ayewo, Sunday, Adaobi, Adeni Fowe, Ahmed Tukur, Aisha Bello, that's 1, 2, 3, 4, 5, 6. Akinya Harry, 7. Alexander Chom, 8. Bolade Omidire, 9. Bukola Daramola, 10, sorry. Chijoke, 11. Chuks, 12. Emmanuel Okoye, 13. Eniola, 14. And then number 15 is, who is 15? Eze. So we're stopping from Eze in group 1. Then group 2 is from Fatima Halilu as 1. Then Fatima Shehu 2. Glory 3. Egulaye 4. Ibitoye 5. Stella 6. There's a name that says is iPhones. So please, if you recognize yourself as iPhones, you are number 7. Kayode 8. Kelvin 9. Lukman Dabo 10. Maimun Ahmad Abdul Samad 11. Midai Samuel 12. Nasser Hassan 13. Jennifer 14. And Boyinde 15. It stops there. Then we take others from Olua Fumilayo till the end as the 3rd group. I don't know if that's clear. Is that okay?
Yeah, very okay, very clear.
So please, let's use this, and then we can come back at exactly 1:45. Let's come for our second class. Osman, you want to say something? Osman Adam Idris. You can unmute yourself to speak. You seem to be in the clinic. Are you on call?
Yes, sir.
You're on call?
No, sir. No, sir.
Okay, it's fine. So please, we are coming back when it's 1:45. So we can all go and have our break, and then we'll come back by 1:45. Thank you very much for being patient with me till this moment.
Thank
all
you,
right.
sir. Thank you, sir.
Yeah.
Thank you, sir. Thank you.
Thank you, Prof.
Recording stopped.
Yeah, I'm not doing that. He's not very good. No, it's a start. Yeah. You know the difference. So what are they focusing on? You don't see the difference. That's what you're confused. So what was the truth like that? Wait. No, no. Wait. They're crazy like it's not every picture that you always watch. I think it's very useful. You have to say nothing to your own friend. It's not my only one today. That's not what you you know what it's your own. About just like you know you're Maria. What are you crazy at? So you don't want them to maybe they have a I showed you that picture. In the book of Isaiah, it's not a great one. Calm down.
We have changed the name of the town. You can pretty much. Yes, I love beef and turkey taco roll with butter jam. Will that be the table? Tables? So in this class, see, I was really creating some clock. But don't get hurt. Please stop living in fear. Next, all the energy. We're going to decide to say everything. Come on. You should say forward. Just like I'm I am the last dream. Anything that water. We have the so much more.
Hello, ladies and gentlemen, can we start coming back? We have almost 5 minutes or 6 minutes to 2. Are we there? Dr. Jibril Samani, where's the host? I hope the host is still around. Dr. Samani? Okay, the host too is not there. We still have more 5 minutes or so. So let's hold on. Are we back? Can we continue? It's already after 5, after 2. 5 minutes past 2.
I think we can continue.
Yes, because I think we have given more than
I believe
enough
we can
time.
continue. Yes, I think.
So I think other colleagues can join us as we move. Okay, I will appreciate if a speaker from each group will volunteer to have somebody that will speak on their behalf, and then other group members can contribute, maybe from what he has left out, and then we listen to your discussions and analysis. So if we have a speaker for group 1, 2, and 3, can you all please kindly identify yourselves if you're around? You want to speak on behalf of group 1, you want to speak on behalf of group 2, and then that of group 3. Okay, I think we are not sharing slide. Can you see my slide? Is the slide visible?
No, sir.
No, sir. It appears the slide is not visible.
Okay, let me see. Okay, I think we missed it here. Share screen. Yes. Okay.
Oh.
Are we there? Can we see the slide now? Is the slide visible now?
Yes, sir.
Okay, great. So so do we have speakers for group 1? Do we have any person to speak on behalf of group 2? Do we have somebody for group 1, group 2? Colleagues, let's feel free to speak. There is no any wrong or right answers. It's just for us to interact.
Okay, sir. I think, can I speak on behalf of group 1?
Okay. That's Sunday, right? It's Sunday.
Yes, sir.
Ayenowo. Yes,
Yes,
Ayenowo. Okay.
So,
we'll be speaking for group 1. Hold on. Just hold on. Yes, do we have another volunteer speaker for group 2? Can we have a volunteer speaker for group 2? We have gotten one speaker for group 1. Do we have somebody for group 2 that is going to speak on behalf of those in group 2? Okay. Do we have somebody now for group 2? Okay, any person for group 3? I think we should just go ahead and start listening to Dr. Sunday while others join, perhaps we'll get those that will speak on their behalf. So let's look at the slide for group 1. Yes.
Okay, sir. Thank you, sir. I want to appreciate you for this presentation. It has been well educative and informative as well. So as regards to the case study 1, informed consent and autonomy, that patient refuses a recommended procedure. So in a situation whereby the patient refuses a recommended procedure that the patient doesn't want that procedure to take place, what is necessary for us in order to maintain ethical professionalism and ensure that the patient right is actually upheld to the utmost, as taken as utmost priority in taking a decision on treatment procedure. However, having declined, there are sequence of steps through which you can take in getting the patient to understand the importance of that procedure. That is 1, explain the details of that procedure for the patient. Okay. If you explain the details, you explain the importance of it, the benefits, and also if the patient declines, you equally let the patient be equally aware that, well, I cannot enforce the decision on you. You have your own autonomy. You have the right to decline and
to refuse the treatment.
You refuse the treatment. But then you should
These are the consequences.
But yes, it should equally be explained that the consequences of decline is equally there. So I will explain all this. That is not to say that if there's any other method that require that we actually benefit the patient, but not to the maximum optimum benefits. Which you need let the patient to be aware as well. So because there are some cases that can make the patient not to accept a particular procedure, possibly because someone must have done it before and it has been injurious. If another patient has undergone such a procedure and the negative effect of it is outweigh the benefits, somehow a new patient who probably wants to undergo such a procedure may decline that because of his experience with another patient who has had such a procedure before. And when that happens, any patient that you are introducing this procedure to may equally want to refuse it and in order not to, and decline completely. But then that does not mean that a procedure that which someone suffers can be replicated in the same pattern and then have the same consequences on another patient. So you should be able to explain your details. Like for example, now we have some cases in our area where somebody had a procedure and with a medical procedure and it came down with paralysis. Then came down with paralysis, and because of that medical procedure that patient undergo, other patient or potential patients surrounding that individual, that patient,
are likely going to decline such treatment in future.
Such treatments. But then that does not mean that we should not give our own detailed explanation that two patients may not experience the same consequence for the same treatment procedure.
That's true.
Let's say, for example, a patient that came having back pain, progressive, having some weakness, but then the patient can still walk about. And because of the pain and the weakness that patient is experiencing, he felt, okay, let me come to the hospitals and probably seek intervention. Then coming to the hospitals and then experience this and his procedure is explained to him that this your back pain, the best option is to go for surgery. And then surgery can, though there's an issue of this 50-50, which is very common in our area here, in our own clinic of the world. But in some other areas, it may not actually be the same 50-50 which we are hiding under as the auspices of if there's any consequential effect as regards that procedure. That is the umbrella through which such practitioner want to hide on. That I won't explain to you that it's 50-50. 50-50 is the sense that it could be successful and may not be successful. That is
but definitely nobody will go in for a surgery of 50-50. A surgical procedure does not show over 90% prognostic value. Is not worth it for a trial.
Of course, but then a lot of surgical procedures we're experiencing here are actually going in line with that. Most of cases.
That's because we don't give our patient enough information, the true information, the right information to make an informed decision. You say one person was better, another person was not better. No, 50-50 means if we go in, it's either we get it or we don't get it. So
that is
we
the
pay money for
of
whether
that.
we get or we don't get.
But then, if a patient now, so as I was saying, in this case study, the patient went in and came down with weakness. The extent that patient could not even walk until he was trying to take another options of traveling out, but the option was really not forthcoming any longer. Then the physiotherapist begin to work on this patient to see how the patient can come up with that weakness. But then the evil has been done, which other patients now begin to have a rethink if they have similar problem, won't go to such a procedure or anybody to undergo such a procedure. But then we need to explain all our treatment procedure for the patient in details. And if eventually the patient now decline outrightly, we can now move, we can now go further to see how so our ethical units, the body or the management that is charged to be well informed about this method. Again, we should equally document in details of that procedure and the patient's, the patient's own point of view, so that at the end, because we are working on the ethical professionalism and the autonomy of the patient, our procedure cannot be enforced on the patient. And since we know that documentation is a key to ensure that both the patient and the therapist is equally secured or protected in one way or the other. Then, once that is done, if there's any other options that could actually benefit, because like the way I perceive I should practice, apart from the ethical guidelines that is guiding my principle and decision making, I actually believe that the all treatment option that is meant to treat a patient, it should equally be explored in order for the patient, at least, if you cannot get the one that is 100% effective, haven't you been declined? Then the nearest option should equally be adopted so that the patient will not be seen, because patient is the center line of this. Because truly, when you take patient as a priority, you take every other option that will help this patient, irrespective of whatever option that patient is claiming to have. I believe that equally can as well be our guidelines and the ultimate treatment, looking at it from the point of ethical professionalism.
Thank you so much, Dr. Awo Ayew Sunday. It has been very, very exhaustive, your argument and discussion. We want to know if there are other colleagues in your group who want to chip in one thing or something that they think is left out in terms of informed consent and autonomy, and a clinical scenario where a patient refuses the recommended treatment or procedure. So Dr. Sunday gave us examples where patients are given information and they refuse, and they went ahead to explore more options. So any other addendum or something someone else in the group want to talk about? Is there something he left outside? Group members?
Hello, thank you very much. This is Dr. Akinya on the line.
Yes, thank you very much. You're welcome, Akinya Harry.
Yeah, thank you very much. Actually, maybe there has been some misconception that the patient has that is making him to refuse treatment.
Exactly.
The whole bulk of the duty lies on the professional to diagnose the main reason why he's refusing treatment. It may be due to pain, maybe pain. A patient has told her or him that he feels pain when he goes to there's a common thing that physiotherapists are physioterrorists. There's a common thing that it will be pain, they use pain to treat pain. So it may be issue of pain. So if you're able to diagnose that it is pain, we'll be able to alleviate that. Okay, we'll be mild, we'll be soft in our handling, but we still need to get the treatment done. So it may be pain, it may be due to the misconception. Just as I said, there's a particular patient in my facility.
Yes, I think Dr. Eniola gave us an example earlier on where she mentioned a patient in their facility, you know, due to fear of pain and refused a treatment. I think she was mentioning massage and all that, and they had to review and take away massage from the treatment plan. So I think you're really right on point that if a patient refuses, the
particular patient I want to talk about.
Yes.
There are two patients in my facility. One had the comprehensive surgery, and at the end of the day, the outcome was negative. He couldn't work again. I even learned that he walked into the operating theater by himself, but by the time he was coming out, he couldn't work again, and he has been receiving treatment. So he now interacted, the person that wanted to go for the comprehensive surgery the second time interacted with the one that had negative outcome during surgery, after surgery. So at the end of the day, this second patient keeps coming to our facility. So when they suggested the surgical management to him, he said, he's refusing it. So because of what he has heard about the outcome of that person, so
exactly. This is a very common scenario among most of our patients. You know, it is what they call the ripple effect. You know, now this rippling effect is all about who knows somebody, who knows somebody, who knows somebody. You know, now there is one of the emirs in our side here. He had a surgery, and of course, it got to a failed back syndrome. Now, imagine somebody who is of that caliber controlling a whole group of people of a community. So from that time, any person in the community that has a problem and they talk about surgery, you want to be like the king, don't go there. You know, nobody wants to go in for surgery again because the area is unfilled. So it's like that. So it means for you to get the autonomy of that patient, you have to give a very full information in terms of identifying why is this patient refusing treatment in the first place. So we could see there are issues of misconception, misrepresentation, and of course, you know, issue surrounding fear and other perception, you know, wrong perceptions. So all this has to be taken care of. I thank you so much, Dr. Kia. That was a very good point that has also been raised. So of course, are there other persons in the group who wants to still mention something? Dr. Daramola, you have been with us. You have not mentioned anything. I have also Dr. Ifobe in the group. Yes. Are you with us? Dr. Okoye, I'm sure you're also in group 1. I hope our colleagues are all with us. You are not just connecting and not following the discussion. If you can hear me, please, could you make some comments? Dr. Bukola Daramola, Dr. Tijoke, Efobi, and then Chips Iwojuku, Elizabeth Godwin Inseka, and then Emmanuel. Yes. At the same time, speakers for group 2 should be ready. Meanwhile, let's go and divulge some information about the case study in group 1. I have a summary of issues I also postulated. Let's look at it. I said this is a case study of informed consent and autonomy where a patient refuses a recommended treatment or procedure. So I gave an example that Mrs. BG, who is a 65-year-old woman with chronic knee pain due to osteoarthritis, who visits a physiotherapist. After a thorough evaluation, the physiotherapist recommends a series of exercises, manual therapy, and the use of TENS to manage her pain and improve mobility. However, Mrs. BJ refuses to use TENS unit, expressing concerns about its safety and potential side effects. She is willing to participate in the exercises and manual therapy, but adamantly declines the TENS treatment. So in this case here, I've postulated, do you guys think that TENS has any side effects? Do you guys think about TENS having safety issues? Yes, please. Those in group 1. Members of group 1, you can
Hello,
unmute.
thank you very much. TENS
Yes.
is one of the safest instruments of
Okay.
physiotherapy. In fact, in cancer, they said the only reason why they are not using it is because it will mask the pain. Not that it will increase it, it will mask the pain that the patient is feeling. So we won't be able to know the extent of the pain that the patient is going through. So
Yes.
TENS is practically safe. So I think we should educate the patient and make him to see reason why TENS is very safe. We should enlighten him and convince her that the TENS is very safe. Yeah.
Yes. Now, Mrs. BJ here, when she's expressing concerns about its safety, what are the likely issues she could be worried about in terms of safety?
Well, to my understanding,
yes,
I wouldn't know if this Mrs. BJ itself has actually experienced some negative effect of TENS. Others, aside from this present chronic knee pain that the patient is having. But however, if the patient has already had experience of TENS, probably carelessly, one way or the other, the TENS probably bonds the patient in a previous experience. That could be a reason why the patient is taking it to decline actually for any potential, intervention that will warrant using TENS. So these are issues that we need to look at.
Exactly. The point I was trying to make here is for us to understand if a patient raises a safety issue, you need to know what is it that she feels is not safe about that procedure or about the machine. Could it be a perception problem? Could it be somebody had told her? Is it that she has read it? She has an information about it. Do you get my point? So if she does have a wrong perception, then it's easy for you to straighten up with information. Now, if it's something she read somewhere, you are expected to read the same piece and see if, is it that she did not understand that thing properly because she's not a professional? Could it be the book or where she picked the information from is not even an information that is credible? Do you get my point? Maybe just some random website where it is not even scientific. So you need to bring now up scientific basis and backup to show that that thing is not like what she has learned or what she has read. So this is what I'm trying to say. For instance, her safety concern could be, I have a heart pacemaker, and this TENS machine is also an electrical device. And I've read that when two electrical devices come close together with a frequency, it could synchronize, to stop one machine from working. And of course, even as the physiotherapist, you wouldn't want to put a machine that will stop a heart from pumping just because you want to reduce pain. So therefore, if that is her concern, would you have to tell her, oh, I think it's fine, there's nothing to worry about? Or you rather choose not to use that thing based on her concern and quality of care? What do you think there? Group 1 members, I hope you are getting my argument here.
Yes, sir.
So what would you have? Yes.
I believe since the TENS is not being applied close to the heart, it's at the knee.
Yes.
So, so we should just explain to her that the distance is very far. We are going to promise a low intensity and frequency. With that, she will be safe.
But do you have a scientific backup to show to her that your distance between where you're applying the TENS and where her heart pacemaker is, the frequency cannot synchronize?
Not exactly, sir, but at least from experience.
So that is where the argument is. You must go get a scientific backup. Don't forget that these days the internet is so close to your patient that they can gather information much more than you. So, but for you to be able to, handle your patient properly, that's the essence of continuous medical education. You have to ensure that there's this continuous reading that you keep doing. Sometimes you pick up an idea from a patient, you go back and read it up. You follow it up, you find out what are those information so that you can straighten up our understanding about that. Your patient will come from every type of ramification. There was a day I had an opportunity, I was treating the permanent secretary of Ministry of Health. So you can imagine when he came up with something, he raised up an issue, and the way I was opening up the issue, he said, but while I was treating him, I didn't know who he was. I remembered, the present MRTB executive secretary, was the person who gave my contact to that person. And the man all the way from Abuja came to see me, interestingly. So the point here is, you may not know who you are even dealing with, because he didn't tell me who was the patient. And of course, based on the principle of justice and whatever, I just went ahead and kept treating the patient the way he should be treated. So, and then eventually discussions came up, and we came to this juncture where I had to find out, where did you gather this information from and all that, before he laughed and said, there's my card. You can imagine. So sometimes your patient can have more information than you. So please, let's understand that in the principle of informed consent, you have to give the patient all correct and appropriate information that will allow the patient to make an informed decision. Are we together here, please?
Yes, sir.
Yes.
Sir, also,
yes.
Also, I mentioned earlier that the patient needs to be, the procedure need to be explained details. But however, when you look at this scenario that I just pointed out about someone having a pacemaker, and you are going to use terms and the patient trying to decline, probably in a way, you must have not have actually identified whether that patient is even having pacemaker in place.
Exactly. So it means your evaluation too is really not comprehensive
not
enough.
Adequate. So if you properly evaluate the patient and you are able to get the appropriate diagnosis of the patient, aside from the primary diagnosis, there could be some other, hidden diagnoses that the patient will want to get you informed, which every physiotherapist needs to actually listen to the patient. Because most of the time, the patient, just as you earlier said, that the patient had information that may have information much more than concerning that even instrument or whatever procedure, much than the physiotherapy at a point in time. So every physiotherapist must able to put this as utmost priority to diagnose the patient properly, and at the same time explaining that procedure or the instrument to the patient, the implication, the effect, everything that the patient needs to know, so that before you go ahead in administering the treatment procedure. So all these are very, very important for the patient to be aware of, to show that for you to gain the trust of the patient with the use of this procedure.
All right, thank you so much. For group one, I believe we have followed enough, and these are the ethical dilemmas I've been able to highlight for the situation. The first one is about the patient autonomy versus professional recommendation. The patient autonomy is that he has a right to either accept or decline a treatment or a procedure. But of course, the professionals also have recommendations to make. I want to use pens and this and that for you. So when the patient is refusing, and then you feel this is what the patient needs, how do you take care of that dilemma? So as I said, the primary ethical dilemma that revolves around Mrs. BJ's issue is her autonomy. She has that autonomy in refusing the test. While also we need to balance the physiotherapist's need, that is his professional responsibility that he has done to recommend the most effective treatment plan. So if she's refusing that, he must accept that in good faith and then look into all the other paradigms of treatment and see what are the other options you could still use to manage her pain. If she has that singular fear and then you are not able to take care of that concern of safety and adverse effect, then it means you have the moral justification to look for other alternative treatment. So this is number one. Secondly, is about the informed consent. Of course, we have discussed with Mrs. JB, and she had fully understood the benefit and risk that is associated with TENS unit, as well as the potential impact on her treatment outcome if she declines its use. If she doesn't want it, well, we are not likely to have pain reduced as fast as we want. So you have given her all information that is needed. Of course, the principle of non-maleficence and beneficence is that we have shown what she's likely going to lose by not accepting the treatment with TENS. And of course, if she's not going to get harm, if she doesn't use the TENS, there's no harm if she's not using the TENS. But our concern is what are we going to do to enhance our overall health and well-being? So generally, this is where we want the issue about autonomy as well as informed consent to concentrate in such cases we put together. So we should know, in general, the physiotherapy should try to provide the most beneficial care that is possible within the patient comfort level or within the patient understanding of a level of care. So because if she doesn't want something and you must put it, it's something that she's not going to translate as Good. So please, let's go back to group 2, where there's conflict of interest and then there's crossing of the professional boundary. Because
I have a question, sir.
Okay, please go ahead for the case number 1.
Yes, sir. Okay, so please. About informed consent and autonomy. Yes. There was a particular patient, a stroke survivor, who was in the spastic stage. It was very spastic. It should be around 3 on MAS. And the only thing he wanted was his GMP was like 1+ or 1. Wow. So on the upper and lower limb, the only thing he consented to was IRR and EMS. No passive movement, nothing, no matter what, nothing. He did not want anything, and he believed in going to church for deliverance and all.
Spiritual treatment.
Yes, so he would just come to the clinic, get EMS and infrared. Mild STM. If he's getting too much, he's going to scream, and because he wounded me, he injured me like twice. Wow. So after, in fact, the patients, I even tried like making friends with the patients. We'll talk, we gist. While we are gisting, we try to do some gentle STM. So later I started refusing it, that he did not want, but it was not improving. After some months, obviously, it wasn't improving, and I told him I was going to tell his wife. He said I was going to destroy his home, that I should not tell his wife about it. But the wife, after some days, came and said our husband was not improving. Okay, so and we could not tell the wife the husband was refusing treatment. I told my boss to handle it. He also said we should just play along. So in such cases, he actually stopped coming. After some time. So in such cases, or
what do we do?
So what do we do? So
so that's a real dilemma that bridges between ethical and then some fundamental right, because it's your issue now is crossing apart from the dilemma in terms of autonomy and informed consent. We're also looking at the professional boundaries. Okay. Now, as a professional, you know that a stroke patient is not going to pick up functionality of his muscles or body structure by just stimulation and infrared. He's never going to do that. He needs some active therapies. He needs movement therapy, exercise, and all that. But this patient has refused treatment. Now, according to your submission, you have explained to the patient all benefits he's going to have, as well as the risk of harm that is supposed to go with refusing not having those exercises.
Yes, sir.
And of course, over time, he has seen those risks, and lack of his improvement has even caused the family to visit the hospital to make complaints.
Yes, sir.
Now, our concern is we are supposed to ask, why is he refusing exercising? I thought the main thing he wants from that paralysis is his ability to walk, is his ability to use the hand. And then is he not ready to move the hand?
He previously had TIA. So
yes, of course, it's the TIA that will have led to the stroke.
Yes, so he believed it was going to resolve with prayers, which we actually...
that's the perception. That's the perception of the patient.
And he also thought it was too painful. That the stroke, he did believe the former one was TIA. He believed he had, So he thought, okay, this time around, this one is too painful. He actually had a very low pain threshold. Very, very low pain threshold. Just don't touch him. So he could even say we should speed up the session and let him go to church. He had a church program. He could even start physiotherapy session for deliverance sessions and church programs. So we just had that kind of mentality and doesn't want to. And we even showed him he met several stroke survivors that were better, that we even told him they were way their conditions were worse than his own.
Worse than his own.
Yes, and those
now
ones
they
even
have
encouraging
responded
that
and
it
they
might
are
not
making
be
good progress.
yes, and it might not be an easy process, but at least the man would get better with time. But he just didn't want to he didn't want to go through it.
Well,
to me, yes.
Go
ahead. Yes.
To me, I believe in this case,
yes,
if you look at it, the patient declined to receiving a treatment
exercise therapy
procedure that would benefit him, that could benefit this patient. And as she said, probably the patient was having excruciating pain. It's not, his pain threshold is low, and because of that, he doesn't want movement of the limb rather than the TENS and whatever. I'm knowing fully well that TENS alone cannot actually bring substantial results. And now, when you look at this, right from the onset, I really know whether the timing of when the patient arrived the clinic for intervention and the time of instituting for example, like passive movements and the likes, whether that timing was actually wrong, because if a patient arrived in the hospital and you supposedly defer a particular procedure for a long time, and knowing forever, probably the patient is having pain and all this is coming up, and you have been using TENS over the time, and incidentally, you're now trying to introduce this, good procedure and passive movements. That patient, we will know the background, whether he has had experience in the past. So these are things we need to explore to ascertain what could be responsible for patient decline a procedure that's taken to be the best option for patient's recovery. But if a patient is having some experience, so we need to actually explain details at this time around to make sure that we gain the heart of the patient to see the need of this development. Because there may be a gap in between the onset of the condition and the timing when a procedure that's supposed to actually address the issue. There's a time gap. If there's a time gap, and looking at the background of the patient, be apprehensive, going through pains, and discover that moving the limbs could be somehow injurious, so to say, or not beneficial to him. That timing, and now that you are introducing it, that may be a reason for declining treatment. So
yes,
I think
I want to agree with you in this situation. But at the same time, I wanted us to look at deeply in his beliefs and perceptions. Until and unless we're able to take care of this issue of his belief and perception that, number one, the condition he's going through, he feels is a spiritual attack. Number two, and he thinks it's only the church that can take care of this situation. So coming to the hospital, he doesn't see it as a potential room for success of his case. So that's why he's likely not to accept most of things he's not comfortable with.
Yes, it was coming to the hospital because his wife insisted and threatened him. That was why I was coming to the hospital. So sometimes we even come to the hospital, he will sit down at the reception, he will not enter, and spend like 2-3 hours and then call his wife that he's done.
You remember when you mentioned that you said you're going to report him to his wife, and all he could say is that you want to ruin my home, So it means the reason why he comes to the hospital is just to, fulfill the wish of the wife, not because he believes in the treatment.
Yes, sir.
So, and I think that the way forward is for us to discuss with the church, and this is where we're talking about principle of beneficence in terms of taking the pain to move to his church, discuss with the wife, because the problem with the wife is she's going to quarrel and create problem with the man, whom he will still see you as somebody who is not supportive to his case. But we are supposed to pay attention to the issue concerning his what do we call it? We're supposed to pay attention to the issue concerning the church he normally visits, and then let the church understand this is what we're doing, this is what we help the patient, but this is what the patient believes in. I believe if the leaders of the church will speak with him, he's likely going to understand, you know, and then and cooperate with the treatment. So I want to believe that in this case, we need to handle the situation of his perceptions and beliefs before we'll be able to make any significant progress in his treatment.
It's true, yes.
Colleagues, I think case study number 1, we have flogged it as much as possible, and I want to appreciate all group members for the case number 1, that is group 1 members. You've been very, very supportive. You've contributed very well. For those who are in the background of group 1, I have not said anything. You know, I'm going to reduce your marks when we're giving our certificates. So we'll tell your HODs that you are still coming to do some parts, or you're writing another case studies for us. Okay? So please, I want us to interact as much as possible, colleagues. Thank you so much. So for group 2, it's about conflict of interest and professional boundaries. And in professional boundaries, we look at issues of like accepting gifts from a patient. Is it allowed? You know? So what are the issues? What kind of case can come up in this place? Who wants to speak on behalf of group 2, please? Group 2 members. Group 2 members, feel free.
Good afternoon, sir.
Yes, good afternoon. Adaubi.
Lukman Salih to Dabo, sir.
Oh, Dabo, okay, fine. You're welcome, Dabo. Go ahead.
Yes, sir. To talk little on the conflict of interest and professional boundaries, accepting gifts from patients.
Yes.
We have numerous considerations when accepting gifts from patients. Is to reflect the value. Some maintain like collecting small gifts is normal, but
yes.
However, some are understanding that the acceptance of larger gifts will be unethical and improper technique. But before we accept gifts, a degree of consideration should always be given.
Yes.
The essence why I'm collecting that gift. The possible consequences for the physiotherapist and patient relationships and the recipient, the likely intention, why is he giving us the gift and what's the objective? So physiotherapy, we need to focus on fairness and equity when coping with all patients. As example, like some patients, when they give you patients, when they give you gifts, they feel like they want your contribution or your treatment or your care to be more on them, especially during the process of the treatment. You see that we say give this doctor something so that he will have more time to us, which is one of the things that used to spoil the whole of the management. But there is a bond that do occur, that do create when
yes,
and some sacrifices or judgment or even violate some boundaries by demonstrating improper intimacy.
Yes.
This gift may cause disruption in working place. Like, why are they giving gift to Dr. Muhammad, not the policeman? And patient used to have like they used to choose a particular doctor for a physiotherapy. So they say this give this person this doctor, and this used to bring a little conflict among us. Like I remember the certain time a patient always brings one of my friends. Always. So me, the patient comes first, I will just say, Dr. Wani, please come, your patient is around. I don't have that mind. Or they didn't give me that space because I know they are looking for Dr. Muhammad.
Yes.
So caring for patient requires contribution from everyone involved, and that is typically achieved in the disciplinary approach. Everybody needs to give his own quota, and even if you are to collect this, it should be not one person. Or if they bring that gift for you, you should tell the patient that please don't bring that patient directly to me. It should be the whole team member. Everyone to collect. If actually it's just a little gift. But if it's a larger one, then the first instance you need to decline that gift. They say no, we don't do that. And from the first instance, I need to say that there are some hospitals that they don't collect it from the patient. They will say no, not allowed. But collecting gifts, small gifts, or during festivals like Eid, Salah, Christmas, those I see that it's not there's no problem in that. But collecting bigger gifts can cause a serious problem and even diminish the harmony within the workplace. Thank you, sir.
Well, thank you so much, Lukman Dabo. I appreciate your submission. It has been very good. Fatima Alilu, you're raising your hand. I wanted to ask Lukman Dabo, what do you consider as a small gift and what do you consider as a big gift?
If I say small gift, it's like bringing Coke, a package of Coke, package of Maltina.
And to you, it could be small, but to someone else, it could be big.
But those are what.
Okay, let me just let you understand that any gift that will compromise your decision making must be turned down. Any gift that has the potential that will create a conflict of interest that you've been talking about, you know? Yes. Now a patient came in because he's used to gifting somebody, you say, call that person. That's the patient that you will treat. I mean, those are the issues we're trying to see that we try to protect between conflict of interest as well as professional boundaries. There are things your profession will allow you to take. There are things your profession doesn't allow you to go ahead with. All right, Fatima Alilu, please go ahead. Unmute yourself.
Good afternoon, sir. Good afternoon, everyone.
Yes, you're welcome back.
Thank you, sir. So the issue of accepting gifts from patients, generally from a legal point of view, it is illegal. But we're talking about
it is illegal.
Illegal.
Are you a lawyer? Hello. Hold on. Fatima, are you a lawyer? Are you a lawyer?
No, sir.
Then you have to quote the Constitution where accepting a gift is illegal. Do you have it?
Sir, because you are there to provide. If we're talking about,
listen to me. We must understand that there's a difference between morality and legality.
Okay.
There are things that are not morally sound, but it is legal. Okay. So we should choose the words carefully. When you call something illegal, it means according to the Constitution, it's not allowed. So perhaps maybe is it the Constitution of Nigerian Society of Physiotherapy? Is it the National Constitution of Nigeria? So let's understand that before we use terms legality and illegality. I'm just trying to call your conscience to this. Go ahead, please.
All right. So, but if we're talking about the Nigerian context or the African context,
yes.
Yes. You would want to look at it from 2 points.
Yes.
Is it a gift from the patient to you as a sign of appreciation, or is it a payment due to the services you provided? Either maybe you favored that patient over other patients, or you went extra beyond what you're supposed to do.
Yes.
Are you crossing an ethical boundary, or is it just simply an appreciation, which is normal for Africans, for Nigerians generally? People tend to appreciate people that they think are doing good to them.
They've impacted their lives.
Yes, in a one way or the other. So as a professional, you would have to, especially if it's a common occurrence, you would have to look at it and question yourself. Is it a payment? Because I treated this patient better than the other one. I shunted this patient. I gave this patient preferential treatment. I gave this patient more sessions. Does it affect equity in one way or the other? And then after that, you have to, because on a general, I would advise, if it's a payment, you decline immediately. Even if it's appreciation, at the same time you can still decline and explain to the patient that you can appreciate me in other ways, because this gifting can come in different forms, and it might lead to issues to the therapist. So to be on the safer side, let's say it's a monetary gift. The patient tries to give you a monetary gift, and you and in your department or in your center, it is against the rule. You try and explain to the patient that thank you, but this is not allowed in my department, or this is not allowed in my center and all. And the patient might try to insist that this is, I'm just trying to appreciate you and all you've been doing for me and all of that. One thing you can do is you can, if there is a person put in place, maybe a secretary in the department or something, you can maybe take that to the person, or you can suggest that the patient, since the patient is trying to appreciate you, patient donate to the clinic or donate to the department as a whole. And people responsible for that can decide on what should be done with the donation. That's if it's monetary. Even if it's not non-monetary, there should be a system. I would suggest there should be a system whereby these things should be handled in a particular way. Another thing is, after receiving the gift, the therapist has to be self-aware. Okay, on subsequent visits of the patient, am I trying to treat the patient better? I mean, by better, I mean, am I trying to give a preferential treatment to the patient because of what happened, to the detriment of other patients or not? So we have to always be self-aware, and at the same time, for you to understand the reasoning behind patients giving this gifts in the first place, you have to ask yourself, am I divulging too much personal information? Okay, maybe you're complaining they haven't paid us or something like that. The payment is for or something like that. You might be getting too personal with the patient, and that is crossing professional boundaries. So you have to check yourself as the therapist, and if it's not allowed and frowned against in your institution also, you would have to explain to the patient that this is not allowed, and if you want to appreciate, you can appreciate me, you can do that, you can give it to the department or even to patients. Because sometimes even the gifts can be in form of maybe assistive device that the patient has been weaned off of, or maybe an equipment that they are no longer using. You can encourage them to give it to the patient and the donation, to the department. And the donation should be towards the department. So in a nutshell, even if the gift is being accepted, it should be used for the good of the patient and for other patients in the department and for the department, and not for personal use of the therapist.
All right, thank you so much. That has been quite exhaustive and extensive. We appreciate you. Are there colleagues from group 2 who still have something to chip in? Any other person? Well, meanwhile, I think let's go into the discussion I have for group 2. You know, we said group 2 is about conflict of interest and professional boundaries, where we say somebody accepting gift from patients. Now, I have a case I have described of Mr. Ade. Mr. Ade is a 72-year-old man with chronic low back pain, and he has been receiving physiotherapy for the past 3 months. Over time, Mr. Ade developed a friendly relationship with his physiotherapist, Dr. Sarah. As on several occasions, Mr. Ade has brought small gifts, such as homemade cookies, a bottle of wine, as a token of his appreciation for PT Sarah's care. Recently, he offered Sarah a valuable wristwatch. So while Sarah is touched by Mr. Ade's generosity, she's concerned about the ethical implication of accepting such gifts. So this is where we're saying, how would you be able to take care between conflict of interest and professional boundaries? Now, do you think this exchange of between small gifts now to a more bigger gift is likely going to create an issue where there will be a professional boundary breach in this case? Group 2 members. Let me see if I can still remember those in group 2. Eniola, did you stay in group 1?
Group 1, sir. I belong to group 1.
Okay. I didn't hear your contribution. Group 2, I have Bukola Daramola. Are you in group 1 or 2? Okay, Fatima Shehu, are you there? Ogulaye, where are you? Glory Chibondu, you've not said anything since morning. You're in group 2. Glory. Are you guys there at all? How about Stella?
Ogulaye is there. I was trying to unmute.
Who is speaking now? Okay,
Ogulaye.
Yes.
Sir.
You're in group 2 now?
Yes, sir.
So what are the issues we're going to be looking at in this case in terms of breaching the professional boundaries? When you start by accepting small gifts and the therapist started accepting a bigger gift, you think there's a breach of professional boundary, or there is a potential to breach the professional boundaries?
Well, first of all, I would like to say, in the code of ethics,
yes,
is there against collection of gifts?
Yes, that's what we're talking about, the professional boundary. Because
is there any rule
that the fear is this. Yes, there is in ethics, there's a principle that your relationship between the patient and the therapist should just be professional only. Now, the fear is the moment you start collecting gifts, the relationship can grow from patient-therapist relationship to a lover relationship.
Okay, then my second outlook is this. Is the gift personal or is it a general donation? And I have my reasons.
It's a personal gift. It's a personal gift. The gift I mentioned started with the small gift of cookies, a bottle of wine, and then we said we went to expensive
That is totally unprofessional. That is unprofessional.
This is where I want you guys to look at it from.
So, because at my hand, at my place of work,
yes,
some of them, when we reject such gifts, they come back to us, sir. Yes. They now request that, what can they do for us as a department?
Exactly.
Because it is not that we do not want to collect any personal gifts.
When it's a departmental gift, you know it's not meant for you. Just like what Fatima Alilu mentioned earlier.
We involve the management, and they not look for a donation. They donate something and they write their name.
Yes.
So on behalf of their family, they now donate it collectively to the department. And in that sense, it's more honorable and will have protected our integrity.
Exactly. And at that point, it will not allow for any conflict of interest. Because it's not because the person now has given you a gift. You remember when the first speaker, Lukman Dabo, was mentioning that, you know, a patient that you have collected gifts from, it's a patient that has the potential, okay, he will come late, then you will go and skip his file and take him in, you know, or the patient, you know, you start giving preferential treatment. So there's going to be conflict of interest. Those are conflict of interest we're talking about.
For instance, Professor Bello, in my own private practice, after closing and I go and see a patient, I don't accept any offer, even of bottled water. So I make sure I go with bottled water, I go with anything that I need. That way you will have maintained your integrity.
It is very, very important. That professional integrity has to be protected.
Yes, it does.
Protected, and that's where we're going up in this place. As somebody is saying, please, how can I join the groups? Okay, Mariam, you were not in any group earlier, so just take yourself automatically to group 3. Okay? Mariam Mahmoud, you are in group 3. Somebody says group 1, I'm on the road, hence I couldn't talk. Okay. Oh, Daramola was telling us she's on the group. Okay, no problem. It's okay. Now we've tried to see this issue of collecting from a small gift to bigger gifts, and we could see what the problem is likely going to have. I said, while Sarah is touched by Mr. Ade's generosity, of course, she's also concerned about the ethical implication of accepting such gifts. So let's look at the dilemma I have mentioned here. Number one, this accepting of gift is likely going to lead to conflict of interest. I said the potential conflict of interest that you are likely going to have first, it will influence your clinical judgment on that patient. And then you will not be able to give, it is also going to compromise the quality of care you want to provide. Because this person is beginning to touch your soul. Now, when you needed to do some vigorous thing that it's going to maybe, you know, it may be painful for the patient, say you want to manipulate the patient, but you don't want the patient to now complain because you have had this attachment of emotions in your work with the patient. Don't forget, this is the reason why in ethics, you are not allowed to treat your family members. You have to give someone else to treat your family members because of emotional attachment that will compromise your clinical judgment. So this is one of the reasons that we don't allow, you know, the therapists to treat their family members. Number 2, I said it will make you cross the professional boundaries. And it is very, very important that we maintain our professional boundary at all times, especially when it has to be in the therapeutic relationship. When you accept too many gifts, especially when the gifts become valuable gifts that can touch your heart, it's likely going to blur these boundaries. Because accepting a Rolex gift, an expensive dress, before you will know it, it's going to be like you're dating each other. So that's, that's belittles your professional integrity, even in the face of that person. So you need to protect and stay between your professional boundaries. Fine, you could see somebody you like, but let that emotional relationship be captured outside the halls of the hospital, not inside the hospital. If for any reason you are getting attached to the person emotionally, then whenever they come to the clinic, you have to absent yourself from that vicinity. You don't allow yourself to treat the person again. So you must understand that. And number three, it's going to create a problem in the trust between the patient and the autonomy over of that patient. So we must learn how to balance between the patient trying to express gratitude and of course require upholding your professional integrity. Because one major problem that comes under this is a patient who just wholeheartedly wanted to give you a gift without any attachments, and then you as a physiotherapist, just coming abruptly and clearly to refuse the gift without producing some reasons, that will not make the patient feel bad. It's also going to blur your interaction with that patient. So you must learn how to balance between these two. So these are the issues that we're likely going to face according to this group 2. Let's look at the issue of the third group, because we need to rush, please. I wanted us to finish the whole program by 4. Please, let's see if we can finish up quickly. So any person from group 3 who want to talk about resource allocation and justice in terms of prioritizing patients with limited resources? Does anybody want to say something there? Members from group 3 are the highest number because you are more than 20. Group 3.
Afternoon, sir.
Good afternoon. That's Theodora.
Hello.
Yes, go ahead.
Yes, sir. The little thing I could get from this topic on group 3 was that resource allocation and justice. Talking about resource allocation, there are some factors that can affect it, or rather make it to be in progress. Limited resources like staff, equipment, facilities, getting it there, making sure that they are put to good use. Then prioritizing patients based on their clinical needs and urgency. That is how quickly these resources can get to the clinics.
Yes, we're with you. Go ahead.
Okay. Then I know that for public health clinics, for public health, they aim to reduce population health risks. That's what I could find. Then for resource allocation decisions, they affect the infrastructure needed to respond to health risks over time. Then talking about justice, there should be distributive justice, that is ensuring that these resources are gotten to patients with equal needs. Then clinical equity, ensuring fair distribution of resources among patients with equal needs. Then advocacy, in case these things are not gotten there, physiotherapists can advocate for these patients by mentioning the needs for these patients. That's what I could get.
Yes, thank you so much, Theodora. Do you have a case you want to present for us to have a good understanding about this?
Okay.
Other members?
Yes. Okay, I remembered when you said something about okay, I remembered when you said something about PPE. I just learned that personal protective equipment. That's like gloves.
Yes.
Talking about gloves, yes. So I remember a scenario where I just graduated when I was in my final year. they told me to go and get gloves from the nursing decks, and it was a very funny scenario, the eye movement and all of that. They didn't want to give me the gloves, and we really needed it because I was already preparing for my clinical exam, and I have to carry out some certain things, and I definitely need those gloves to operate on the patient, like STM. I will need my gloves. So when you said that, it just reminded me of back then. So things like gloves. Then another issue, ultrasound. Poor patients need to use the ultrasound, so you have to be timing it. Then at times some persons will want to be chancing another person like that. Infrared, the same thing.
Okay, thank you so much. Thank you so much.
So
we really appreciate your contribution. Yes, I believe members of your group have gotten a good understanding of what you're trying to say, and I will urge them to still contribute. So I've seen a lot of them in the group 3. I have Zabiri. Zabiri is one of a seasoned therapist. She has been working for a very long time. Please, Zabiri Rashida, if you are there, I want to hear your point on resource allocation. Rashida. Like Rashida is one of close to an assistant director presently. Are you there? I hope she has not just dropped the phone and left. Okay, I still have other members in the group. Temitayo, are you there? Shola Bade, are you there?
Is it possible we contribute from other group?
We wanted the group members to make their contribution first.
Okay, sir.
Yes. Chinoye, are you there? Where is Dr. Kelvin?
Hello, ma.
Hello. Okay, hello.
Yes,
You
ma.
can go ahead.
Yes, ma.
Yes, please go ahead.
Yes, ma. I'm not sure of which case study I actually belong to.
Don't worry, we have put you in group 3. Just go ahead.
Okay, ma. But I don't know if I could talk on that of case study 2, because that was what I thought I actually belonged to.
Okay, it means you just have to hold on. We'll come back to 2. So we're trying to dive into group 3 now. So if any other person said they want to contribute to group 3, you are free to talk. Any person that wants to talk about the group 3?
Okay, sir. Thank you, sir.
Yes, please.
There was one, I don't know, the resources that we are talking about.
Yes.
I don't know if
it's healthcare resources. It is medical equipment as well as
yes, I understand. The medical equipment, and probably does it equally split over to resources in terms of amount of money paid by patients to be seen in prioritizing their needs and individual patients. What do I mean? Let me just explain. When you look at situations whereby, because it's an experience I had some years back in an institution where patients arrive in the morning, everyone then seated down. Meanwhile, there are some who were told that their payments, the money they pay for the service is lower than some who was predisposed to be VIP in a category of VIP. And when these patients were coming in, they needed not to actually sit, generally wait the other patient, those who pay higher. And therefore, they have to come straight and enter whatever cubicle or attend with the therapist, and the therapist attend to them. Incidentally, a VIP, one highly placed VIP, you are put to be a commissioner. What he paid for was that he paid less. I wouldn't know what has actually happened, but then he paid less lesser money that were in the categories of those who were to be seen whatsoever time they desire to be seen. I mean, the therapist. Now, having sat down for so long, he was observing what was going on. Many patients who have not actually, arrived earlier, they were just coming and they were going in and receiving treatment, going out. Only for this man to discover that, wow, it has been a while I've been here. I was not attended to. What was the reason? It was being told that you pay a lesser amount. And because of that, you are not, that was the reason why you were not being attended to on time. Those who pay higher came in and they were receiving treatments. In this scenario, sir, without other resources, in terms of money paid, that there is a preference in regards to somebody, let's say somebody paid 10,000 naira, someone paid just 3,000 naira. So those who paid 10,000 were coming in without necessarily going through the queue, and they were called in to receive treatment. While those who paid 3,000 naira were just left until it gets to your turn. These are
you see, before you leave that side, that is a gross misconduct and an unprofessional, practice. Because you are supposed to pay attention. We have mentioned earlier this morning that resources must be allocated based on needs. Number two, based on proportionality. But it should not be allocated based on personal connectivity, that personal connections. Should not be based on socioeconomic status. We mentioned it should not be based on geographic location. That because yes.
Institution, sir, the institution has actually categorized it. To that institution, it appears it is the norm.
Yeah, but that institution must be alerted that they are practicing an unethical healthcare system, in which it means the poorer I am, the more I have been denied access to care, which is the number one human right. It's a human right issue, and it is culpable to punishment by any law. Even the law of the lands in Nigeria. So please, should not be acceptable, even if it's the management. And that is why sometimes in that principle of beneficence, you can go out of your way to fight not only some injustice in the system, but some injustice even if it's being perpetrated by the authorities. Because you just want the best for the patient. So please, this is the reason why we are here today, to learn these principles and put them into practice. So I want to believe it is an unethical practice, and it should not be accepted even by clinicians in that system. I don't know how you will feel, for you that a patient just came in now because he paid 10,000, and then a patient has been sitting there since 2 hours. I don't know how you feel, how morally you're going to feel that you came in and you're able to pick up somebody who just came in now, but somebody who has been sitting waiting for long. I don't think, you have that sense of humanity to do that. So please, it is wrong, even if it's been perpetrated by the system. Yes, please. Yes, members of Group 3, does anybody want to make any contribution, or we just go to what I have for you? Because I have prepared also another slide where I put out a case up for you. Now, this is the case distribution in terms of resource allocation and justice, which we're trying to prioritize patients with limited resources. So we're trying to see where a patient is a poor patient, and then we want to see how we allocate resources based on justice. Now, the case is that Dr. Patel, who is a physiotherapist and working in a community health clinic that serves a diverse population, including many patients from underserved and economically disadvantaged backgrounds. Don't forget, this is a rural clinic. The clinic has limited resources, including shortage of physiotherapists, equipment, as well as treatment slots. Recently, the clinic has experienced an increase in patient demand. That is, their workload has increased, which has led to longer waiting times and difficulty in providing timely care. Dr. Patel faces this ethical dilemma of how to prioritize patients' treatment to ensure fair and equitable access to limited resources. So you can see this case is a classical case of what we go through in our numerous clinics. And it's the same thing of what the last speaker just came up with. So do we think we should just collect more money and treat those with more money and leave those who don't have money? No, it's not correct. So these are ethical dilemma. Number one, the distributive justice. How do we fairly allocate these resources among the patients with varying needs and background? Please, who would you give what and what will you give what? Group 3 members. How do you want to, let me go back to the case so that you remember. I said the clinic has limited resources, which includes shortage of physiotherapists, equipment, and treatment lots. So how will you enhance distributive justice in terms of allocation of physiotherapists, equipment, and treatment slots? What would you do to ensure equity and justice here? Group 3, please. It's almost 3:30. It's even after 3:30. Yes,
good afternoon.
Good afternoon. Sorry, I don't know why I'm sounding like a woman. I've been saying I'm a man since morning.
Okay, sorry, sir.
Is it that my voice is not heavy enough?
No, sir. No, sir.
Okay, go ahead. Go ahead.
Actually, so okay. About this, I would say some of the things have been said in previous statements.
Yes.
That they made so far about prioritizing, allocating, how to allocate resources based on and based on need.
Yes.
I'll say that's one, based on the need of the individual.
So how do you think needs will come up here?
Yes, ma'am.
How will you define the needs? Don't forget, this is a physiotherapy clinic. Okay?
Yes, ma'am.
A lady earlier spoke that Theodora, when she mentioned that in a clinic, there's only one ultrasound machine. And then there are about 4 or 5 people waiting to use this machine. So how would needs come up in terms of allocation of that equipment for treatment? What would you do in terms of needs?
Okay, in terms of needs, what I would do in terms of needs, I would look at those whose conditions need it the best at this present point in time.
Needed the most, exactly. Who are those whom that equipment is likely going to benefit highest? All right? So that's what we mean in terms of needs. Now, in terms of the treatment slot, that is the number of times, how would you allocate that?
About the number of beds, what I would do is, I know that physiotherapists, except for a good setting where we have defined specialties at different units already, or if it's a growing place like this place, they will likely not. I don't think they will likely not have
specialist clinic. Of course, there are no specialist clinic.
No, I mean, I actually mean to say special rooms for specific rooms for different specialties. Maybe pediatrics, cubicles.
No, we just have one general department. We just have one general department.
Exactly, ma. So what I will try to do to make things balance is look at the number of patients we have in. We can look at the number of patients we have in at specific categories of specialties. For instance, we can have, if we have maybe 5 pediatrics patients and 20 orthopedic patients trying to use a single cubicle, trying to use about 3 cubicles. What we can do is to ensure that a pediatric patient is being seen in one of the cubicles, while the remaining two will be used for patients who are in who have orthopedic cases, to ensure that each of the we're not just attending to specific categories of people. And looking at small children, usually when they stay for long, they would have tendencies to want to feed them over. There will be tendency for their parents to want to feed them over time, which may even prolong even their stay eventually in the clinic. So in such a case, we might want to prioritize based on the number of patients at specific specialties. Maybe go to pediatrics.
Well, I thank you so much, Dr. Temitayo. Your point is clearly understood, but I want us to know that you're working in a rural setting where you don't have any specialty. So Theodora is giving us like a hint. She said if it was her, she is going to triage all the patients. The thing is, we're going to look at who are those that need the presence of a physiotherapist most. That is, who are those who need the treatment most? For instance, if I have a patient with an acute low back pain, and then I have a patient with stroke, and another patient with CP, who do you think among these three requires more treatment in a week than the other?
The one with acute low back pain.
So the acute low back pain requires more often treatment. So I'm going to, you see that's what we call the needs, you know? So I'm going to give maybe this guy 3 times in a week. What about the CP child? What about the CP patient? What will I do? Maybe once in a week. Because you know it is not a condition that improves based on your treatment now. It takes a long time to see changes.
Yes,
is that not? And it's not because you are not going to treat the patient for the rest of the week. All he needs is what? How do you intensify the home program? You could give this patient to go take care of themselves by themselves. And the same thing with the stroke patient. Can they follow compliance? Can they adhere to home program? If he cannot, then you may have to see him twice in a week. But the other guy might be seen 3 times. So this is what we're talking about, allocation of resources based on what? The limited resources you have should be allocated in terms of justice, you know, by prioritizing the patient's need. So I hope we're following, please. Group 3 members, are you with me?
Yes, sir. Yana so kake kira ma. Na fito late.
Who are those disturbing? Please call the attention to mute.
Wallahi ga ma sai wurin 2:30 na fito
sannan
na haɗu da mai dan are sau ka gama zagaye da ni muka gama gantalo.
Who is that talking, please?
Mariam Salisu, please mute yourself. Railway station.
If you have a number, please call her.
Sannan ya kane sai kuma ce ba zai maki ba. Shi da kusan 1 hour ta kowa ne.
Si surutu for goodness.
Fitowa na daga gida ba zuwa in zo nan ba. Ai bai fi 7 minutes. 2:34 nan da na yi
number of that person.
Ina fitowa. Ina kulle gida ina fitowa.
Okay. Mariam Salisu Dugaji. Please off your mic. All right. I think we just make progress. For this case, I've mentioned that these are the ethical dilemma that we'll be looking at. You know, patient autonomy and needs, we have to balance it. That's what we mentioned. In terms of the equipment, number of days you should come and all that. And of course, the professional responsibility. This is making decision based on clinical judgment and ethical principles that rather on personal biases and external pressures. So that's your professional responsibility. Should not be based on, okay, will they like you? Will they not like the way you do it? And all that. No, that should be based on what have you seen after evaluation and after treating the patient. Please, we're going to leave it like that. And I hope all the 3 groups have understood where we're driving to. And I believe if we go back to it, we'll still be able to catch up more with it. Because we have 20 minutes left, I want us to rush this issue of professional boundaries, because we have not discussed it before now. I said professional boundaries are the spaces between the professional's power and the client's vulnerability. Because usually in our setup here, the doctor assumes the position of the alpha and omega, while the patient assumes that of the slave. So the patient, the doctor always sees as if, the patient is at his own mercy. Whatever decision he makes is final. That is not seen. The professional boundary allows the patient, the professional to know that the patient has a right, the patient has some autonomy and all that. I said these boundaries ensure safe and therapeutic connection between the PT, that is the physiotherapist, as well as the patient. We must ensure that maintaining professional boundaries is crucial for protecting both the patient and the healthcare giver, ensuring a relationship that is based on trust, respect, and ethical behaviors. Now, one of the importance of maintaining our professional boundary is that it helps us to maintain trust and respect. If you don't act professionally, people will not respect you. Your patient wouldn't respect you. Your patient will not trust you. So when you have a clear boundary that distinguishes between your professional job and then your outside job, it helps you to establish and maintain trust and respect within the healthcare system. Of course, when you maintain professional boundary, it tends to create patient safety, because it ensures that because you're a professional, you don't go to any way that you harm your patient. Do you understand? That is, you try not to exploit your patient or to harm the patient. There's a case of something that was brought to me, a physiotherapist that scammed his patient of 3 million naira. You can imagine that. That was a scandal everywhere in our system. So you can imagine how you have rubbished your profession in the face of that situation. Of course, you must understand that if you maintain your professional boundary, it helps to enhance the professional integrity. So most time we must understand that when something scandalous come up, the moment the name of a physiotherapist is mentioned, then we should know that that thing has trampled with our professional integrity. And we must at every point in time know that we are guardians of the profession, and therefore we want to uphold and maintain its integrity. So any health, it means professional integrity will help us as healthcare providers to act in accordance with our ethical guidelines and professional standards. So therefore, another thing that our professional boundary will do for us is to create clarity. That is, everybody should know the role that and expectation, and this is what we are doing. It is not a love-like relationship. No, I'm here to take care of you. I'm here to make sure that you start working. I'm here to take care of your pay. You know, the roles and expectations are clearly defined. And it has this predictability. The moment you start working, I have discharged you. So these are professional boundaries. Now look at the key areas of professional boundary. Number one, we have physical boundaries. I said the physical boundary involves maintaining appropriate physical distance and avoiding unnecessary touch. The moment you begin to touch your patient in where does not connect to the treatment you are giving, it begins to create a distrust. It begins to create a problem. And besides, as a professional, your physical boundary requires what? Consent. Please, we want to walk on your back. Are you okay if I take off this part? Are you okay if I expose hair? Are you okay? Could you do this? So it has to be on a professional touch, not unnecessary touch. We should understand there are emotional boundaries. Emotional boundaries will involve maintaining a professional distance and not become overly involved in the patient's personal life. A patient came into your cubicle and you're discussing about how much is this now? How can I buy that in the market? And how do I, before you know, you're beginning to enter into personal life, and then dating beginning to cross in. You have jumped across the professional boundary. We should understand there's this power dynamics. Healthcare professionals, inherently, they hold a position of power. Especially the patient look up to you for their care. So you think you have the key. to whatever you can do to them. But it is essential to use this your power responsibly. You should avoid any action that could be perceived as coercive or manipulative. Like I said, some colleagues as surgeons or whatever, they use this power to scam or rather to force the patient to consent to surgeries and so many things that are not ethical. For instance, there's after the workshop I held in Abuja early this month or last month, one of the participants just called me recently that, sir, you discussed about this low back pain issue. Now there's this patient in their facility that the patient came in, the doctors diagnosed Pott's disease. 2 weeks later, they started this patient on anti-TB, and after 2 weeks, they took the patient for theater for laminectomy. The patient came out of theater and the pain became worse than what the patient used to have. And he's been referred for physiotherapy. She was asking me, what physiotherapy would she use? That there is nothing she has put that has not increased the pain of the patient. Ladies and gentlemen, do you think there was an appropriate decision-making in what transpired between this patient and the medical surgeons? Are we expected to have a TB patient who just started anti-TB 2 weeks later to go through surgery? Do you take an infectious spine into a surgery? The likelihood of spreading the infection will be higher. We're talking about TB that you are supposed to take a medication consistently for at least 6 months, 1 year, or 18 months. But after 2 weeks, the patient has been moved into theater. You will realize these are for personal gains because the doctors there, they own the power to manipulate the patient that, okay, if we do this and this, your pain will go. So it's an unfortunate situation. Please, we must understand that these things, a lot of things are not correct because people don't stick to their professional boundaries. We must understand when you have dual relationship. For instance, you are the physiotherapist treating a family member. You can't do that because you have a relationship with that patient. So that relationship is going to create a conflict of interest in your treatment. If it's a son that you are treating, you may not be able to do it well. Maybe the emotion attached to that will not allow you to do it well. At the same time, if you have an excellent affair with somebody and you are the one doing the treatment, it's also going to create a problem. So you must see how that if you have a significant relationship with a patient outside the clinical setting, then that is going to obstruct your treatment and decision-making process. There are also financial boundaries. When we're talking about accepting significant gifts or financial incentive for patients can blow off these professional boundaries and create conflict of interest. So how do we now try to maintain appropriate boundaries? The first thing is there must be clear communication. In clear communication, I say you must set the expectation early. The moment you come across a patient, you must tell them, this is me as a physiotherapist, this is the role I'm going to be playing, this is what we attempt to achieve, and the moment we get that, that's all what we are doing. Of course, when you are discussing with your patient, you must use professional language. Avoid using overly all this familiar word that is being used in town as jokers. And no, you are not there to joke. You're there as a professional. So, and then you don't discuss things that are not related to the patient's treatment or care. Number 3, I said you should always educate the patient about professional boundaries. Letting him or her know that there are things that as a professional, you're not allowed to do. For instance, if you're working in a system or in a setting where they do not even allow you as an individual to accept gifts, you must set that right from a go to let the patient understand. In my setting, we try to do things. When you say thank you, you could only write it for me in a card or a banner or something. But we don't accept. We're not allowed to receive any types of gifts except in your kind words for appreciation have been written on a keyboard or something and sent. So this will help the patient to know they should not go beyond professional relationship. Of course, you should be able to dress properly. As a physiotherapist, you don't just dress anyhow, you know, your dressing should reflect the nature of your professional work. Sometimes you could wear a t-shirt, a jeans, because what you want to do requires you to do in that manner, all right? But you can't come as a physiotherapist in a babariga. How do you want to do your work as a physiotherapist in a big babariga and all that? So you should dress appropriately for the job. And of course, you should always adhere to ethical guidelines. There are a lot of framework we're going to see. And of course, try to avoid dual relationship. Try as much as possible. Don't engage your treatment in somebody whom you have other relationships with. So that will help you maintain your professionalism. Of course, sometimes we also learn how to manage our personal disclosure. We need to let them know that you should know that, you know, there are information that you shared with the patient. There are information patient will share with you that you must not let any other person know about it. So because if you keep sharing too many information about yourself to the patient, then you may lose your integrity. At the same time, if you allow the patient to keep sharing too many information to you, that will also make sure you cross your professional boundary. The major thing we want you to do is to focus on the patient, that the interaction should be on the patient needs and his concern. You should be able to redirect all this conversation. When the patient is trying to go out of it, you try to bring the patient back. We're now looking at how do we handle this gift and financial boundaries. I said, number one, you must be able to follow the policies of where you're working. Every setting have their different policies, but you should know that there are gifts that are not allowed. But whatever it is, if you want to decline the gift, you should decline it politely. And then you should be able to refer to a clinic policy of gift acceptance. So it means if you are coming up with a new clinic, please put this at the back of your mind as a policy of the of your setting, that this is how you want to handle financial boundaries, professional boundaries, and acceptance of gifts. So when you don't accept it, you should be able to suggest alternative ways for the patient to express their gratitude, like writing a thank you note, providing a testimony about what you did, or donating to the clinic or related costs. All this we have mentioned, this is how we should handle it. Now, let's look at the patient right. We told ourselves that patient has the right to informed consent. Patient has right to privacy and equitable treatment. All these are the rights of the patient. We should be able to ensure and respect the patient's dignity and privacy. We should be able to protect the patient confidentiality as well as personal information. When there are personal patient grievances, we must learn how to attend to that and address their grievances and concerns. For instance, a patient just came and said, I've been sitting here for the past 3 hours. Nobody called me. You can't just go, can't you see we are treating other patients? No, that is not right. That's not right. The patient has a right to his grievance. So we must listen and find a good way to address it. So we must create a mechanism in which patients should create their concern. And there are some ethical decision-making framework you should follow. And I said there are a lot of steps. The first one is that when there are ethical issues, you should first of all identify the ethical issue. When you see the issue, you gather relevant information about that issue. Then you look at the ethical principle and values and see which of them has been breached. So we should explore other options and consequences of how to take a decision about what has happened. Then later you should come back and evaluate the outcome, and then you reapply. So we should always use a lifestyle scenario. These are the group activity I have said we're going to do, and we have done them. And then we go into our professional guideline and resources where you are supposed to see a different guideline. I've made these there. Well, you look at the WCPT guideline. I'm going to send it to you after the lecture. Of course, you all have NSP guideline, and then you should continue in journals and workshops. So in general, I have several key takeaways I want everybody to go home with today. The first one is that all what we've been trying to discuss from the group discussion to this point is about how how do we maintain our professional integrity? The first thing is, what are the ethical principles we must follow? We have talked and discussed about the principle of autonomy and informed consent that patients should have. We should know patients have that autonomy. We have discussed it. We have discussed about principle of beneficence, maleficence, and then justice. All this has brought us to understand that the whole thing about ethical, ethics in healthcare is about patient-centered care, because everything we're doing is what will enhance the improvement, the quality of life, and then the healthcare system of our patient. It's about the patient. Number two, we should be able to ensure that our informed consent are well and correct information that the patient has been able to read, understand, and appreciate. And therefore, whatever choices the patient is making, we are ready to honor that choice. Of course, we have also seen that in making all this information, we will try to balance the benefit with the risk. Whatever the benefit is and the risk, we've shown it to the patient, and then we'll be able to take whatever comes out of that. I've also been able to see about equity and justice, what we need to do, what we call the distributive justice, allocation of resources. We should put at the back of our mind equity, and that in that equity, our needs and other things are things we should put in forward, the needs of this patient, in allocating the resources which are usually limited, that we should pay attention to. And of course, we talked about maintaining professional boundaries. And lastly, I talked about continuous ethical education, that we should continue to seek information about ethical education. So in conclusion, I'm saying here today that the ethical practice of physiotherapy is not just about adhering to rules and regulation, but it's about embodying a compassionate, a respectful, and principled approach to patient care. I say, if we're able to integrate our ethical principles into our daily practice, we will enhance the quality of care we provide and contribute to the trust and respect that form the foundation of therapeutic alliance. Ladies and gentlemen, I thank you for listening, and we can now entertain our questions. Thank you, everybody. So it's open for questions and answer. We have 1 minute to 4. I tried to rush just to be sure that we drop at 4. So if there are other questions, comments, observations you want to talk about, please feel free. You can open your mic.
Thank you, sir. I want to sincerely appreciate you for all that you have spoken about as regards to professional boundaries and the topics generally. However, when you look at professional boundaries, there's the aspects which I would have loved that it should equally involve, is the issue of knowing our limits as regards to enhancing patient care in terms of interprofessional referral, whereby patients at a particular time where we need to understand that this condition, social medical experts
Yes, go ahead.
will be in the right patient's care. These are challenges over the years that we have been experiencing, that somehow is at the particular
your
time when
yes, your network is breaking, but I think I got your point, where we should have also added our professional boundary in terms of our role, where it starts and where it stops. So we're going to be looking at that
Contact.
when we come to talk about evidence-based practice. So I know about that, but it is not included in the syllabus of our ethics. So we want to look at that under evidence-based practice. Where do your practice start? Where do your practice stop? So hopefully we will run another program on that some other time. Thank you so much. Yes. Do we have another person? Do you have any other observation? Any other comments? It's already 4 o'clock, 1 minute after 4. Do we call it a day, colleagues? Yes, it has been very massive. I thank you all for being patient and for standing with us till the end of the program. It's quite interesting that most of us are still actively participating, you know, for the whole of this hour to be online and to still remain resolute. It has been quite interesting, and I appreciate you all. I thank you all for participating, and I hope it was worth your time, right?
Yes, sir.
Have a wonderful evening. Bye for now.
Thank you, sir. Thank you, sir.
Can I take you back upstairs? No, I don't want to stay. Okay. Let's talk about it.